Investment Committee later. Thank you, Suzanne. Any other absences that we know of, Peter, please?
Three actions open on the action log. In August board meeting, we'll bring back our formal response to the Shadow Board's recommendations in relation to their review of violence and aggression to staff. The CCP review that the board talked about recently, that will be covered in the Integration Committee board report shortly. And just to draw the board's attention to the final action, which is I've highlighted here in amber, in relation to the Manchester recommendations, just to note the update here from our head of resilience, basically saying that we haven't quite got the clarity in relation to future funding, but we're doing all we can in the meantime. I think I'll suggest that we close this action on the log. It is something that is picked up in the natural course of business of the Audit and Risk Committee through the EPR annual assurance, so anything that arises from that will be addressed through that committee.
Okay, unless anybody disagrees with that, I'm happy to take that forward on that basis. I know, Paul, from your perspective as chair of the Resilience Committee, you're happy with that?
Yeah, it's just been quite a while. I mean, I'm not sure how hopeful we are that we will get any funding on this. So it's just a risk we probably have to live with, unless we get an awful lot of money.
Jen?
Yeah, the amounts of funding are quite considerable for us and for all ambulance services, and we're in a common position with all of the rest of the ambulance sector in the challenge that there is in putting forward responses to those recommendations and brokering agreement about how that is to be implemented. The process is ongoing, so clearly there is a kind of a risk around it, but that is a shared risk for the sector, and there is a process of engagement with NHSE who are endeavouring to sort of broker what is a reasonable and sustainable outcome, which I would agree with the recommendation we close this from the board action log and continue to manage it through the resilience route, which is where those discussions are taking place. So yes, it may not be possible to fund everything in full, but that is an ongoing process of discussion, and the risk is well understood.
Thank you, Jen, actually. So if I could go to my report as chair. So I'm sure many of you, well, all of you will know this will be my last meeting as chair of CCAM. I will say something at the very end of this meeting. But in true tradition, Peter has helped me draft a report, and I'm going to actually say a few things that aren't in the report, which is chair's prerogative. Firstly, I just want to remind people that the NHS Modernisation Bill had its second reading in the House of Commons or is in that process at the moment. I mean, this is really important for all of the NHS going forward. First and foremost, obviously, we all know that NHS England will be absorbed within the department. One of the most recent initiatives related partly to that is the establishment of regional chairs. Now, there is a regional chair for the South East. Recently attended a meeting at which he spoke, very impressed by what he's seeking to achieve, but there is a clear focus in his remit to address issues or help NHS providers focus on health inequalities, and he will be in the process of engaging with all chairs in the South East over the next month or so. So that will be very important for my successor. But the important message we need to get across that CCAM is a major provider of NHS services and a fundamentally excellent system player. So we've got a lot to contribute, and we need to be part of that debate going forward. The second point I really want to make relating to the Act is the focus very much on the legal entity it will give to a single patient record. This is really, really important going forward. It will help in the services that we provide to the communities which we serve. And I think it really underpins more than anything the importance of our digital strategy and the joint work that we are doing with SCAS around the joint CAD recruitment, procurement, and getting that in place. The single patient record, I think, if implemented effectively, will have a major impact on improving health outcomes and the services which we and other providers deliver. So I just wanted to say that in relation to what's going on nationally. Last week or the week before, last week, I was very pleased to join Jen at her Meet the Chief meeting at Chertsey. Again, it was well attended, good level of debate, and I'd just like to say thank you to colleagues at Chertsey and Phil for organising that event. I'm sure Jen will say a little bit more about it in her Chief Executive report. The other interesting thing was that 2 weeks ago, Peter and I hosted a visit by the former chair, David Astley, and the former senior independent director, Lucy Bloom, and we used this opportunity to go and have a look around the new EOC development at Nexus House. I have to say, I'm incredibly impressed by that facility. I think it will do a lot to support our people working there. Training facilities are excellent, and it's been done in a way that all the people involved there have been engaged in the process, so it's very much their working environment. And I'd just like to express my thanks to Corinne, who took us around, showed us everything, and the work that she and her colleagues have done in making this a reality. I think we started the refurbishment last November, so in the space of 6 months, I think what has been achieved is considerable. There is also the new corporate headquarters, and it really, really has the feel of a professional identity, which I think is very important for CCAM and the group going forward. So I think it won't be long now, but I would really encourage everybody to have an opportunity to go and look around the new 111 and 999. It is very impressive. And thanks also to Simon's leadership, Simon Bell. Two final things from me. One is we are in the beginning of June, which is the 3rd month, am I right, of this financial year. We are very much focused on delivery. We recognised when we set the plan for this financial year that there were challenges. Importance of maintaining our position in terms of performance around the C2 mean, because this is a good indicator of how quickly we can get to patients when we need to. Hear and treat, we know that we have got to do more in this space, and at the same time we have an ambitious cost improvement programme. Now all of those are a little bit off track at the moment, I think that would be fair to say. Now that's not unusual within any organisation at this time in the business cycle, but I do think it's important that at the moment we are in control of our destiny. We've got about 8 months to go, is it 9, 10 months to go before the end of the financial year. So we have opportunity to make sure that we focus relentlessly on achieving what we have set out to achieve. And I would encourage NEDs and executives to very much have that in mind in terms of the questions and assurance that they get this morning. And finally, can I remind people that as we go through this morning, this is an assurance board. Members of the public, stakeholders are expecting us to be confident about the level of assurance that we're getting. So can I ask you to be very mindful of using the integrated reports that are available to us so that we can maintain the golden thread of relating performance back to our key objectives. That's all from me at this stage. Could I then, Chair, go to, I think it's Karen, you're going to actually, as Carl is not here today, you're going to give us an update on the integration report, from the integration report. And would you mind just saying what the integration committee actually does? Because the members of the public, they may not.
Certainly, I'd be
Thank
pleased to do that. So the integration committee was established by the board in Q4 last year, primarily to oversee the delivery against the 5 key areas of collaboration agreed by this board and by SCAS. And the committee meets in common with the SCAS committee. And we've had, I think it's 3-4 meetings now, and the work programme is progressing well. So this is one of our regular meetings, and we met last on the 26th of May, and there are 2 main areas of focus which we were discussing in this particular meeting. The first is the CAD EPCR procurement, which is something of which is business critical for our organisation and others. And many of you will remember that following the decision in the board, we took a decision in the board in April to approve the commercial strategy and the route map to move towards procurement. So that's been going ahead. And basically what we looked at in the committee is progress against those milestones. Both organisations have slightly different considerations in relation to requirements for these products, but I'm sure if there are further questions on that, we can direct those at the appropriately skilled people to answer the detailed questions. But we are on quite challenging timelines, and I think that was one of the preoccupations of the committee, about making sure that we do deliver on time, and that we're ready. We've got the related business cases done for awarding the contract in October 26 through to October 27 to implement the systems. So work's been going on between both the executive teams on that. And I think in conclusion, I can say that notwithstanding some of the challenges, there is a feeling this is a good example of deeper collaborative working between both organisations. And the committee supported the proposal to schedule a workshop in the summer to ensure deeper understanding of the plan prior to the October board meeting. I think that's all I want to say by way of overview, but happy to take questions on that one. But the second item, shall I go straight on to that we discussed, or do you want to pause there, Chair?
I think it's worthwhile just pausing. I just want to check if there are any questions. Peter, please.
Yeah, hello. Just a very quick question. Within the report, Carl mentions the executive teams of both trusts had a debate around the whether or not it was financially the money would be there. Is that something that is now sorted, or is that still a problem? Do we know?
My understanding, it's still work in progress. Could somebody help with the detail on that, please?
Yes, thanks for the question, Peter.
It's a movable feast.
Yes, both teams are working closely together on that. The financial profile required is different for both trusts because we start in different places. And the analysis of what the final solution should look like is a work in progress and will be presented as part of the full business case, which is planned to come to board, aiming for the October board. So at this point, it's still a work in progress.
Thank you. That's very helpful. Thank you.
Harbhajan and then Paul, is that I think.
Yeah, I just want to make sure we're still on track because these are very critical systems. We haven't got much time. The teams are working really well together. It's not easy. We're replacing our most critical systems, having to retrain everybody. So, but we have to get over this next hurdle, which is, are we on track?
Yes, I'm happy to report. Both executives met this morning and approve the next stage of the process for both CAD and EPCR. So I'm happy to report we are on track.
So we're going to start the procurement immediately.
So we will start the process immediately.
Thank you.
Harbhajan, and then I would like to come in, but Harbhajan, please.
Yeah, just to say, I mean, obviously, because we are looking at a piece of work that's being done jointly, this was also discussed at the SCAS board yesterday, and so the same conversation was being had. The biggest issue is still around actually where the funding, because there is still a significant funding issue, which I know both teams are looking at, and actually the implications of that are also quite different on the two organisations, just in terms of, because we are talking about potentially two different products and then potentially moving to a single one. So it is a conversation that is occurring across both organisations, but the need for speed is recognised across both.
Thanks, Harbhajan, for that assurance. Can I just say, I'm a bit concerned because I thought the business case was coming to the August board. That's what the previous chief executive said to me. Is that not the case? Or
Yeah. Yeah, it will be the October board, Michael, and that timescale is in line with what we need to do to maintain the programme. We need to enter now into a period of engagement that will allow us to understand both the supplier landscape, the costs, the funding position, and the internal collaboration that we'll bring to this between SCAS and CCAM, which will enable us to manage the risks and the challenges of transition, and thus get the very real clinical and financial benefits of doing this. So it has been agreed, I think, to update that time frame to October, which we do need to take that time, but we're assured that that still allows us sufficient time to make the migration deadlines that we have. So it is October, but I think we're assured that that will work.
okay, I take that assurance. Look, can I just say, it doesn't need me to say that, you know, digital projects do not have the best track record going forward. I would also say to you, no disrespect, but you know where I'm coming from on this. Can you? I tell you now, and I'll give you this for clear. 15 years ago, I was asked by the then Controller of the Audit General, and he actually said to Peter Gershon, who was head of Government Commerce, could you find me examples of good, successful IT projects that we can actually create, you know, help create a non-risk averse culture in Whitehall? We found one, and that is going international. So it's nothing against you, Nick. No. But all I'm just saying to you is, the alarm bells start ringing when I hear, you know. So I presume there is a margin built within this critical path. You've lost the margin now, aren't you? You're reducing that down quite considerably. And all I'm just saying is, it's not my problem. I'm not going to be here. But you need to keep Colin very close on this. And I also say to you now that the ICB's eyes are on this as much as anything else. And I'm sorry you're in my line of sight. I'm not getting at you. I'm saying this to the whole board. I mean, there was a clear expectation from Karen as chief executive that this will begin to realise benefits. I'm just giving you a hard time because I think. Yeah.
May I just say, Michael? Firstly, nobody came and asked me about successful projects, but I'll take that. But the really important thing is we have spent a lot of time profiling the necessary steps for us to have a successful implementation next autumn, and we feel actually now in looking at it there is a more important step before we get to contract signature now that both trusts need to do together that will ensure a much quicker and smoother implementation after contract signature, and that's why we've moved the timeline slightly. We think it will be more beneficial that way.
Okay, and no criticism, but I return to my point. The public demand and expect quite rightly that these things are delivered on time and within budget. Okay, thank you very much, Cam. You obviously created a debate there, so I'm very grateful.
And there's one more point as well to feedback, if I can carry on, if that's okay. Yeah, good. Thank you. Sorry, were you? Okay. The second item we discussed was the joint clinical operating model, and the committee received a very positive update on the progress of this and the governance arrangements, with a few suggested amendments approved in the terms of reference for the clinical services review, which for critical care, which is being undertaken with SCAS. And you may remember that this is in line with the board discussion we had in April, and that this will be externally led and completed by October 2026. And I think it would be fair to say we were very impressed with the rigour that had gone into this piece of work and setting it up. As someone that's been involved in these kind of projects in the past, I was really pleased to see the level of detail and collaboration and discussion on that. So I'm hopeful that we'll get some innovative solutions and some really helpful steer on the future operating model for both organisations. Alongside that, good progress has also been evidenced around the aligned governance, and a steering group has now been established. The executive teams have been careful not to create a whole new infrastructure, but built very much on the existing governance arrangements at present. And I think it would be fair to say that the committee concluded on both sides of the table that, virtually, that it was another good example of collaboration between both organisations. I'm happy to take any questions or redirect them.
Thank you. Can I ask questions, Peter, again, please?
Thank you very much, and very good joint clinical model. My question really was two of them. The first one is around, would it be possible as we move forward on this board to have an update on all our transition projects? These are just 2 out of 5, and the timelines, a proper project plan, so to speak. I would find that very helpful. And the second thing I would also find helpful as well is that we add this to our risk register, the transformation, because it currently isn't on there. And it'd be good to be cited on anything that could be an issue. Thank you.
Thank you, Peter. Very sensible. Peter, is that? We can make that happen. Yeah. Okay. Thank you very much. Very helpful indeed. And thank you to Carl, and thank you to everybody who's involved in this committee. Thank you very much. Do you want to go on to the shadow board?
Yes, I'd be pleased to do that. So the shadow board met again on the 2nd of June, and the key issues that we discussed then were based on a number of the papers that have come here today. So we looked at the leadership framework, we looked at the patient safety incident response plan, we had a presentation on the virtual care programme, which is very high on everyone's agenda. We looked at the CEO report, and then we had feedback from the shadow board representatives who've been visiting the subcommittees of the organisation, and had feedback from the People and the Quality and Patient Safety Committee. We also had a discussion about the next steps potentially for the development of the shadow board, because it has been running now for a while, and we're starting to think about succession planning, so we're going to be bringing some proposals back on that at some point. I think it's good to say that the shadow board continues to go from strength to strength. There was good constructive challenge, and I'll perhaps bring some of my director colleagues in that were there, and particularly strong focus on delivery, workforce impact and communication. I think it's helpful for the board just to run through some of the challenges that came up from that group. The intention is to bring the voice in, and we are discussing these papers. So on the leadership framework, the challenges and questions that were posed were around how will operational staff access development given abstraction and service pressures? How will success be measured beyond attendance and linked to retention and talent pipelines? How will we ensure consistent leadership standards, including core competencies, for example, project management? And how will we develop diverse leadership pipelines? I think overall, the shadow board concluded that the framework was seen as strong, but noted that delivery risk lies in equitable access and measurable outcomes, which again I thought was a very mature discussion. On the patient safety papers, the questions that were posed were around how learning was consistently communicated to frontline staff, and we had quite an interesting discussion about the differing responsibilities for everybody in the room, as well as what we're doing within the formal comms strategy to try and take these issues forward. How we avoid information overload versus meaningful learning. And there was a debate about it's not just about sending something out on email. So I think we're thinking more methodologically about how we do that. And interestingly also, how do we strengthen psychological safety and reduce fear of blame? It was thought that learning, there are good examples and pockets of good practice in terms of learning from the work that we're doing, but that may not be consistently reaching all staff, and the cultural shift is progressing, but there was a feeling that that wasn't quite embedded yet in all areas. The presentation on virtual care, again, stimulated quite a lot of debate around issues to do with staff retention, attrition, morale, how it might affect individuals in terms of where these new centres may be located in terms of travel roles and working patterns, whether all system partners were fully engaged to support the model, and how much staff had been involved to date and how the concerns were addressed. And again, I think a mature conclusion from the group, which can be summarised as the primary risk is people-related, not strategic or technical, and success depends on clear communication, engagement and training investment. I hope that's done justice for the people that were in the room, but again, I'm happy to take questions, and it may be interesting to hear back from Jackie and Joe, who are coming to talk to that group.
Very, very happy to comment. It was an absolute pleasure to talk with the Shadow Board about the leadership framework, and I would absolutely echo that the feedback was incredibly constructive. The questions were very, very helpful, and it does mean that we can take away what is really important to representatives actually of the people for which the framework has been designed for, and focus our efforts in the areas that we know are likely to be the ones that might trip us up. It's very, very important that the framework isn't merely a document. It's not something that we want to kind of put on the wall and say that looks pretty, but the important thing is actually the meaningful development that it helps us to support staff on. And I think in particular, I'm drawing some links between the feedback on the framework and the PSERP in terms of how we sort of tie together the leadership behaviours needed to deliver on the PSERP. But I think one of the things that particularly resonated with me following the discussion is the importance of how we crack access to development in a way which is equitable for people and doesn't reinforce, in fact, make worse the inequities in leadership that we currently exist with.
Thank you. I always love coming to the Shadow Board. It's incredibly helpful to hear from representatives across the organisation and now people that are going to be practically applying some of these concepts or strategies that we come up with. I think just aligned to Jackie's point, I came in after Jackie had spoken about the leadership framework, and I said, oh, this is a great segue to what we're now talking about, which was really lovely to then see the kind of connection between all of the pieces of work towards our strategy, and always incredibly invaluable feedback and constructive challenge.
Thanks, Joe. Can I just say, the Shadow Board is really excellent. I mean, there was such rich material in what you summarised, Karen. And so thank you for the work that you've done on Tuesday in sharing it. But could I ask members of the Shadow Board, I always do this, is that a fair reflection? Is there anything, I'm sure we haven't missed anything, but there's anything you would like to add to that? No? Okay, thank you. Well, thank you for that. And can I ask my colleagues, any questions that people have got from what they've heard? I mean, we will follow on in our discussions about some of the papers, but anything that anybody else wants to? No? Okay. Harbhajan, please.
Michael, certainly on the leadership framework, a lot of the comments that were made were exactly the same conversation that occurred at the People Committee. Fundamentally, it's a great document. Now, how do you lift it off the paper to make it into something real? So again, when we come on to that particular item, maybe we can pick up some of that in a little bit more detail.
Okay, thank you.
Yeah, no, you were certainly busy in that few hours, weren't you? I just wonder what happens next. I mean, do you review it again in a few months? Because it'd be good to test because it'd be difficult to solve all those problems, but that we are making progress. That's now we check.
If I may, so yes, I think we do keep running themes going for the committee, and we are inviting then something to go back on an agenda at a future point, and we did agree that with these items. We thought that would be helpful. I think the other point to make about it is I think it's a really useful reality check for us in terms of, are the things that we're discussing at board and doing at board resonant with the workforce? Are these the things they see as priorities? And I think just matching some of those, I think, I get a good degree of assurance from that yes, that is the case. So I think if we can replicate that with some of the other governance structures that we're bringing in around the divisional models, I think that would be we're getting all sorts of triangulation then about how things are going and also what we should be doing.
Just wanted to very quickly come in on the shadow board to Paul's point around sort of closing the cycle. Obviously, colleagues will remember the violence and aggression work that the shadow board undertook that Jo will touch on later in her update, just to close that circle back, started in December. And also as a result of that, just to, without adding any pressure to Philip and Hannah, you'll remember Chair Simon suggested that they should present that work on behalf of the Shadow Board to the ACE Council. So, at the sort of highest level of our representative body, which is happening next week. So Hannah and Philip are doing that. So given that's in short time, I thought it was worth mentioning just to show how things are followed up on and taken forward. Thank you.
Thank you. I didn't know that, and that's really, really excellent. I was just thinking as well in the context of when you gave the presentation at the ACE conference on the shadow board, it was a sellout, wasn't it? It was standing room only, And so I think there's genuine interest across the ambulance sector in this initiative. So I'm really glad that you're able to go and obviously feed back to the board what you hear from that. So thank you very much. There's inevitable, when there's change in chair or chief executive, transition, what will go on. I had conversations with Colin, my successor, and I know he's very supportive of this, the shadow board and the insights it can provide. And as Janine reminded me, he was in the audience at the conference, really, and very enthusiastic about it. So, I think this is going to go from strength to strength. And, and ultimately, it's your organisation. You should have an opportunity to help shape it. So thank you for all that you do and contribute. I am very conscious that it does take a lot of time. You've got to read the papers, you've got to, get up to speed. So, thank you for that commitment. That's really excellent. Thank you very much. Could we go on to your report, please, as Chief Executive? Thank you.
Thanks very much, Michael. And I was delighted in drafting this report to see just how much has been going on over the last few weeks. So it's quite a long report. I will take it as read and just highlight a few summary points that I wanted to focus on, and happy, of course, to hear any questions and discussions. So first of all, a theme of change. There is always change in the world and in the NHS. And just to note briefly, because points have already been made, that I'm very grateful to Simon Weldon for his guidance to me in my time here and in setting me up for this period of interim chief exec. And to note also the moves that have been mentioned, Margaret's retirement after so many years' service to the NHS and Jo's opportunity to join the board, which is fantastic. David's opportunity to experience the Kent system and sort them out as well. And ably then seconded by Simon taking on responsibilities in Fleet and Make Ready, and Richard stepping forward to hold the strategy portfolio, for which I'm very grateful. And then, of course, Michael, tragically, your last board meeting with us. And after 7 years, I believe, so we'll have an opportunity, I'm sure, to thank you properly, but you've been an enormous support, even in the short time we've worked together. And of course, then we look forward to welcoming Colin to the organisation very soon. So lots of changes, but change is an opportunity, and an opportunity to make some choices and to show the grip and the control and the agency that we have over our improvement journey and our future as an organisation, as part of a group and as part of the NHS system in the South East region. So brilliant to celebrate the CQC feedback that we had. Receiving the good rating for UEC and EOC is fantastic news and deserved by the members of staff who deliver those services every day and all of the structures that we put around them. It is critical that we maintain that grip on the quality, sustainability, effectiveness of our services. As Michael mentioned, our licence to operate really is dependent on continuing to deliver against our agreed balanced plan, both financially and performance-wise. And in part, but perhaps not entirely, due to some of the demands that we've seen in the system, the hot weather, the busy bank holiday period, we are behind where we would wish to be 2 months into the year. So I really encourage everyone to think through how we can retrieve that position, how we can be brave and proportionate in how we use resources and how we deliver services. And that's a topic we're managing and overseeing very robustly with the executive through our senior leadership team and through our divisions. So still lots to go for, really good plan that we have, but we do need to really, really keep on top of things. And in so doing, pay attention to our future strategy. So accelerating virtual care as the primary first intervention that we offer people who contact us for urgent and emergency care. And I think there's something for me around the cultural shift that we need to make to see the virtual care clinician role as absolutely a critical, valued part of our workforce, not a secondary responsibility, not something that people do if they can't do something else. There are so many brilliant clinicians working in the virtual care space in our organisation and who could be working in that space. I really want us to see that workforce shift as something really positive that continues to value all of the roles that we have already, but introduces something really important to the way that we're going to deliver care as an organisation with all of our people moving forward. That will be supported by various digital shifts, as we've talked about, and also by a culture of learning. And it was interesting to hear as I kind of shift into the theme around equality, diversity, engagement, working with our people and on our culture. It was really interesting to hear triangulation between what was said in the Shadow Board report and what we heard at Chertsey in the Connect with the Chief session, which is very much about how do we shift our culture and use the leadership framework and the experiential learning and the support that people can receive through that to be about learning from what happened and the feedback we received about a situation or an incident, as opposed to sometimes feeling that there is a complaint about you or there's blame about something that happened that's personalised. So we're still working on shifting that culture. And it's interesting when you talk about culture because sometimes you can't really describe why people feel like that. And we need to think about like how do we work together through leadership to change that framing that people bring to feedback and make it a positive opportunity for learning and recognise the role of proportionate responses in that. So that was a really enjoyable day at Chertsey, and there's been loads of other engagement opportunities which I've very much enjoyed, celebrating success, playing in the football match, although I'm not sure you could call my personal contribution more like running around aimlessly than actually doing the footballing bit, but hopefully brought some cheerleading to that. And also absolutely delighted that we were joined by SCAS colleagues in our team. It was a joint leadership team, and I think that was really important as we look towards the future. Just wanted to mention the pleasure I had in taking part in a number of events relating to our volunteering and community resilience teams, particularly in Eastbourne. I'm very fond of Eastbourne at the moment, but we have volunteering and resilience going on all over our patch, and wanted to sort of in Volunteers Week, which we're in at the moment, just to pay tribute to the contribution of everyone who undertakes volunteering roles, and the importance of continuing to focus on our community resilience and volunteering strategy and thinking about how we bring that to a wider community and engage particularly with those harder to reach or more disadvantaged communities in order to address some of the health inequalities that we see, for example, as a very important objective to improve cardiac arrest outcomes within the board assurance priorities. Finally, looking to the future, I've already mentioned the collaboration with SCAS. We had a very successful discussion this morning around the CAD EPCR, and the shared digital platform and the joint clinical model are going to be really critical to our future strategy as an organisation and a group. So just to confirm, we are focusing on delivering our plan. That's the fundamental that we need to do. We do that in a high quality and effective and sustainable way. And that's the foundation on which we can build with Colin and with Simon Ashton as he joins us to an even greater future as a coordinator of urgent and emergency care in the South East.
Thanks, Jen. And you're also doing, I don't know where you get the time, when is the cycle ride that you're doing?
2 weeks' time, and I'm very excited to be joined by a number of colleagues around this room. No dropouts, I've got my eyes on you. Sarah, David, Joe, and Lucas from our resilience team. It's the Sunday the 21st, but you're going to have to cycle fast to catch up with us, Michael. No cheating on an e-bike.
I don't know, I can't remember when I was last on a bike, so you don't want me around.
Stop practicing.
Okay, can I ask any questions of, please, thank you.
Thanks very much, Jen. And yes, there is a lot going on. I just wanted to say a couple of things really. First of all, well done on the outcome of the CQC visit. That was hard one. I know a lot of hard work has gone into that over a long period of time. It's very satisfying, especially for me, who's been here for 5 years, and I've seen that has been quite difficult to get movement on that. It's a real shame that on the well-led for the first one that we just missed good, really, because of the restructure. So that's a real shame, but I know that's going to give dividends in the future. So that's really good news. Just on your point about virtual workforce, and we did discuss this, didn't we, at Quality Committee. I mean, it's really important that we recognise that they are an equal member of the workforce. It's an important skill set, and we allow for that training and support in our leadership framework as well, because managing a virtual workforce is also a skill set. So we just need to recognise that they have absolutely equal parity with our physical workforce, if you like, who are going out on the ambulances. We also need to recognise perhaps that to our own workforce, sometimes the virtual role is not as exciting as the physical presence. So we just need to talk about what that means for them and make sure that they are engaged. Leadership framework, I can't better the questions from the Shadow Board. I think they're excellent questions. I think the proof of the pudding is going to be in the data. So that would be really helpful to see that back at this board, about the data and how we're doing on that. My actual question was on end-of-life care, and I see that you're doing some really good work there, which is very welcome. Having had personal experience of Marie Curie, I know that they do an excellent job, and there's clearly opportunities here for the community providers as well, you know, how we work, and they have that integrated role to bring the voluntary sector together with the ambulance sector, so that's really helpful. And it may be a question for Richard and Jackie, I don't know, but if I remember rightly, and forgive me, I've got holiday brain as well as jet lag, I think that the end-of-life care model is one that we are working on. It's not one for producing this year, but it would be good perhaps just to get an update on where we are on that for this board, because I think, again, it'd be really helpful to see the data. If that is starting to make a difference, it'd be really good to see what kind of difference that is making. But as I say, it might be a question for Jackie and Richard.
Richard, happy for you to contribute. Just to say, end-of-life care is one of our pathway of care priorities for this year, and I'm sure we would be happy to have a further discussion about it, either at QPSC or board. Richard, I don't know if you want to briefly update where we are.
Thanks, Jen. Yeah, really good question. It's an area that the board has been concerned about for some time. We had it as a priority for last year, and we didn't get to where we wanted to be, not because of any problems internally, but because the whole system is pressured around patients at the end of life with the closure of hospice services and reduction in funding and voluntary funding. It's a big issue for us. So we've maintained it as a priority into this year as well. We've upskilled our staff. We've put on additional training through key skills in how we manage patients at the end of life when they're at their most desperate, really, to maintain really good clinical care in the absence of other services around us. But a priority for the coming year is to work with commissioners and work with community services to encourage a more joined up approach so that patients don't get to that desperate stage where they need to dial 999 in very difficult circumstances. In terms of level of confidence of us being able to deliver something meaningful in year, I think it's going to be a real challenge because it does require all system partners to work together in a setting where, as you know, funding is reduced for the charitable sector. But so it's going to be a challenge for us, but it's an absolute priority for us.
Do you want to say anything, please? No. Thank you.
Can I just come in from a QPSC perspective? We have discussed it in depth. I think it's also clear to acknowledge this isn't a commission service for us. This is something that we do for our patients when they fall through the gap. And a big way forward for this is having our integrated care records that are happening. So our crews are aware immediately that this is an end-of-life patient. The lack of hospice support is evident, but also so is the out-of-hours end-of-life support across the system. And hence, most of our patients are calling us overnight and first thing in the morning in dire straits. CCAM will always respond, but I think from our system partners and our commissioners, as Richard has said, we need agreement because our average time on scene for these patients is over 3 hours. And that is a lot of time we're spending to those patients who need us, but obviously we're backing up our other patients who are also waiting and need us. So QPSC is keeping a very close eye on this and the pathway linked to this.
Thank you, Liz. Is there anything you wanted to respond, Jen, particularly in engagement with commissioners about this? It's come up at meetings I've been with commissioners, but you're more into the detail than I am.
I mean, I think it's a broader challenge for us as an ambulance service. End-of-life care is a very clear example of where our staff, with absolutely the right intentions, because we're here to help, are stepping into a gap. And we can do that in other pathways as well. There are examples of this in the mental health care pathway and other settings where either a real or a perceived gap in services or a lack of trust perhaps in being able to hand over to other services is a problem because, as Liz said, what we're doing is we're looking at the case, the patient who needs our help in front of us, and we're not, being able to maintain visibility of all those other patients who are also awaiting our services and may have an even more urgent need. So we are engaging with commissioners through the Strategic Commissioning Group and our oversight meetings and indeed more locally. One of the advantages of the divisional model will be across the field operations divisions, we are embedding more local partnerships between the dispatch desks and their local systems, in particular their acute hospitals, but also the community and mental health and the third sector services in those areas. So out there on the ground, we hope that that will enable us to engage more directly with the services that we need. But this isn't an easy problem to solve because resources are limited, and actually, there are interactions with the way that society works as well now, with perhaps less family support than there might have been in the past, and that's a challenge. It's tricky for any of us to resolve.
It's a good discussion. The one thing I would say is that certainly I mentioned at the very beginning about the appointment of these regional chairs. And the regional chairs, you can't expect them to be doing everything, but they are reporting directly into Penny Dash while NHS England continues, and she is chair of NHS England. So I think it's quite useful to have a body of evidence that you can present to him about, ever since I've been here, 7 years, CCAM has always done stuff that it's not been commissioned for, which Liz said, and we don't get paid for or acknowledgement of. And there's always going to be that element within the system. But when it represents such a systemic challenge, I think we need to have the evidence and be able to present that. But it's a good discussion. Thank you. Could we actually go on then, Joe, to talk about this brilliant result from CQC? So thank you.
Yes, thank you. So I feel incredibly privileged to be here at my first board and sharing with you the outcome of the 2 CQC inspections from our field operations in EOC that were published last week and evidence the sustained improvement journey that the Trust has been on since 2022. Both services have achieved an overall rating of good, with very strong feedback on safety culture, patient-centred care, system working and staff professionalism, representing, as I said, that significant improvement across both services from their previous requires improvement ratings. And I think it really demonstrates for me the embedded learning, improvement and high quality care and really resonates with me. And I think, as Subo said, you know, I've been here in the organisation for 3.5 years now and have really seen this journey come to fruition. All domains within the EOC report have been rated as good, which is fantastic. All but one of the domains for field operations were rated as good, with one domain, which was well led, still rated as requires improvement. The reason for that was there was a regulatory breach identified under Regulation 17 of the Health and Social Care Act, which relates to good governance. And this was in relation to CQC identifying inconsistent leadership and some governance gaps with the move to the divisional governance arrangements that they identified weren't fully mature at the time back in September when they visited us. I am pleased to say that since the inspection took place, the Trust has already implemented a strengthened divisional governance framework through the Clinical Integrated Operating Model workstream that has been underway. And we recently gave an update to CQC on that they were very happy with. An action plan is currently being articulated on this to share with them in alignment with the existing programmes of work and the strategic priority on this included within the BAF already. The overall Trust rating remains as requires improvement, and that's pending a well-led assessment, so that won't change until we have our well-led assessment, and we don't yet have any indication as to when that might be. Both reports are now being reviewed in detail, and a gap analysis will be undertaken to identify any further opportunities for improvement. I do want to just take this opportunity to formally thank all of our staff who have worked incredibly hard over the last 3 years to really support and drive this improvement across the Trust. The board is asked to recognise and take assurance from the significant progress made, acknowledge that achievement of staff that I just alluded to, and note that any further focused actions are in place to really strengthen the governance and support that continuous improvement moving forward. And we will continue to have ongoing oversight of that through QPSE.
Joe, thank you. That was very clear. And just to start before we have discussion on behalf of the board, I would very much echo what you've said and your thanks to all CCAM people for the considerable investment in their time, dedication and compassion to get this to where we are. It's a reflection on them, really, and that's the important thing that we mustn't lose sight of. May I ask just one question for Liz, really? I think we were aware of some of the issues. I remember talking to Margaret around the governance issue, so we had some expectation of that. Liz, from a quality perspective, are you confident that's moving in the right direction?
Yes, definitely. And I think just to reiterate that we had the draft report many months ago, And in addition, I'd like to thank Margaret in her absence, Jo and David, who did a factual evidence-based challenge back to that draft report to get us where we are with the good ratings. So a lot of work had gone on and subsequent evidence given to the CQC inspection team that made the difference. But of course, the challenge, as Jen has said, is we have to maintain this level of good and be able to evidence that. And I'm certain that Jo and the quality team will continue to do that, but that the QPSC will gain assurance on a regular basis that we are on track with that.
And then Margaret told me about the analysis that you did, which was slightly different to what is traditionally done. So all credit to you. But I'm just interested, did that analysis highlight anything that you thought we need to be thinking about this for the future?
Goodness. So the first thing to say, when I want to qualify, because members of the public may be listening to this and thinking, oh, we've put a challenge in, so we've fought really hard to move the needle. And we did, but I think I speak for Margaret in her absence, and Jo will correct if I'm not. But when we read the report, those of us that have been here, as Sue said, for a few years, seeing the whole journey, we felt very strongly that the whole story wasn't there. So we came at it from a point of view of what's the story here that we think, and we appreciate the scope complexity to do an inspection and see the whole story. So it was a great opportunity to be able to complement the whole picture. I think it's really important to recognize that the inspections happened early in September, I believe, and that was just off the back of having done quite a big change in the organisation. And again, for members of the public, we've done a big change, which is to realign ourselves to the division so that the way in which we deliver services are closely aligned to Kent, Surrey and Sussex, which are the ways in which then the systems typically work together. And that's really important by way of changing the mentality of the organisation, making sure that those decisions can be evolved at a level that is more relevant so that the services can be better organised in partnership with local partners to be able to deliver the best care. And that's a big change for this organisation. So there's a big piece, I think, that this, we've talked about the divisional governance, and that's, I think, what's reflected into that kind of requires improvement well-led. And I think that's right, because I think that's really important that we continue to pay attention to a board to say, is that culture maturing at a divisional level? Are those clinical triumvirates coming together well? Are they really feeling empowered to make those decisions? Are those partnership relationships with providers locally, are they robust? And to an extent, are they a bit independent from the executive team? I think there's something really important around tipping the balance of the decision-making and the ownership and the empowerment from what has historically been a very exec-led organization to be something that's a bit more devolved. So I think that's the one thing that I would say is still part of the journey. And I think it's really useful in a way that requires improvement is still there to remind us, because otherwise we may kind of forget about it. I think it's really important that we are very aware of it and continue to work with our divisional teams to embed that.
Okay, David, thank you very much indeed. Habijan, did you want to come in? I wasn't thinking.
Yeah, I mean, being a relatively new non-exec here and reading the report and the journey that the organisation's been on, I think it's a real credit. And, I know for some people that requires improvement it feels like disappointing, but actually remember where you started from, and so actually this is a continuous improvement piece of work. Actually good isn't where we want to be. We want to be outstanding. So it's that next level and that next step up. So from my point of view, actually reading this, I thought, wow, actually, and the divisional piece is going to be quite critical to this, because actually traditionally you've always sort of had a very sort of traditional pyramid, and actually it's making sure that those people who are actually managing that divisional piece, and that's why it ties back into all of the work around leadership and actually what are we doing around that and skilling people up. And I think that's going to be really critical for the next phase, to make sure actually what we're putting into place is effective, and then we're appropriately measuring it and then going back and re-evaluating it on a regular basis.
Thank you.
Can you hear me now? Yeah. So yes, congratulations to everybody. huge amount of work gone into this, which has paid off. So I think, again, I think it shows that if we focus on these things, we can really get there. And I'd also like to thank Liz as chair of QPSC, because I think you have kept us on track with those issues, and it's been really helpful to have that constant coming back to things. More generally, I think there are some interesting points that have come out from this, and just general comments really. One is around the risks of governance gaps appearing when we're in transitional periods. And I think this has been a useful case study, but I think the important thing will be, well, how are we going to use it to future-proof? And on our risk register, this is mentioned about some of these issues, but are there any specific learning points that we might build in when we're looking at some of the other softer services, or also looking at the collaborative work that we're beginning to do? And I guess that's something for the transition committee to consider. I think for me, the other thing I've taken from what David has said is there's something about, in a way, we're being judged on what we give them and also what our people and our patients tell them. So I think some of those things we have more control over than others. And I think if we have some deficiencies in giving the data that can help evidence how well we're doing, then perhaps we should be looking, and I know we are constantly doing that, and we're going to have a board development session in the autumn about what it is we're measuring, how we make the data work for us, how we make sense of the data. I just would like to keep that very much in view, because I think there are some useful lessons here. Thank you.
I really like the point you make, Karen, about governance gaps, because you're quite right, we are going through major change and will continue to do so for the next couple of years. So that's really important. Can I say, having been an external auditor and done so many reports to Parliament on government performance and wider public sector, you're really spot on. You really need to be, what I would say, a really strong client. If you've got a really good story to tell and you can back it up with evidence, you shouldn't be frightened of doing that, because at the end of the day, you've got more information than they've got, really, and you need to be able to. But the important thing is in articulating it very clearly, but in a way that that is quite humble. This is what we've got to say in that space. So I think that's a really strong lesson. Can I ask one final question, Joe? Because if a member of the public listening at this might say, this is great, how as a board are you going to know that this performance is maintained? And I think I know the answer, but in the public domain, it's worthwhile you just explaining that, please.
Yeah, so I think what this represents is that over the past 3 years, we have developed the frameworks and the processes of delivering quality through our everyday care, rather than checking for quality. So this isn't about checking for quality to know whether you're doing it right. It's about getting the processes right from the outset. And for me, the CQC report provides validation that that is what we've done. So we've gone back to the foundations to get those right. Having said that, there are still a number of assurance processes that we have in place. So we have a quality assurance visit programme now, where we regularly take visits across the organisation to sites, and we'll check things across clinical effectiveness, patient safety, patient experience. We also have all of our teams who are set up to identify any kind of early warning signals that would be coming through to now tell us through that data and other qualitative evidence to kind of align us should we be veering off track in the future. So I'm pretty confident now that we would be able to identify at the earliest opportunity should that be happening. And just could I possibly just come in on the previous comment? I think what I wanted to say was it's a really interesting conversation that we've had with CQC actually, and Margaret and Simon, when they were in the organisation, met with CQC to talk about this, because what we identified through our experience with CQC this time is that and this is probably a historical thing, that CQC aren't necessarily set up to assess organisations when they're in the process of transformation or continuous improvement, but actually when it's kind of a done deal and they finalise that. Now, recognising that CCAM and lots of NHS organisations now are always going to be in this perpetual state of change and continuous improvement, and rightly so, we've been working with CQC to help them to understand and us to understand what that might look like and how we might tell that story, as you alluded to, Michael, but also what they can do to support all organisations, including CCAM, who are on that transformation journey.
That's a really, really, really good point. I was going to conclude this discussion just to finish where I started, and just to again reiterate the thanks of the board to CCAM people for the investment in making this happen. And I'm really assured by what you said, Joe, around this is business as usual now, really, rather than a one-off exercise. So thank you for that. We now go on to the main standard item of the board, and it's framed around the 3 pillars of our strategy, and it's an opportunity for the board to get assurance that we are making progress on those three pillars, and also to give assurance to our external stakeholders who might be watching today or who may read the minutes or watch the recording. So do you really, to start, can I ask Peter to introduce the new BAF and set out how we're using it for 26-27?
Thanks, Chair. So in the pack, so in April the board received the outline BAF. In the pack today we have the full board assurance framework for 26-27. It includes the 6 priorities that the board's agreed, the risks as we have identified them to their achievement, and in addition the 9 commitments from our operating plan that the board signed off back end of last financial year. To Peter Shield's point earlier, it does include in the BAF the group priorities and related. There's actually a BAF risk that relates to the group as well. This first version is to provide detail, so the focus really for this version is to provide detail of the plan for the year ahead, so it includes the scope, strategic milestones, expected benefits, and the governance and reporting arrangements. The version's there for the next meeting, and thereafter we'll resume the standardised approach to reporting against delivery, which will be tracked by each of our board committees, and in the pack later you'll see the relevant committees cycle of business where it shows the alignment to the strategic priorities. So just a quick reminder then on how we use the BAF and IQR at the main board meeting, i.e. today. So these are set out in the agenda as the primary documents to support the 3 main pillars of the agenda, which aligns to our clinically led strategy. As we usually do, we'll start through the assurance through the relevant board committee, starting with quality in a second. But just to reinforce the feedback, so board colleagues, we had a development session a few weeks ago where we talked about board effectiveness and in particular how we approach it through our committees, and some of the feedback, Chair, that you reflected in your board report was that both, although the relevant chair leads out on the discussion, it's very much for the rest of the board, both exec and non-exec, to contribute cross-referencing the key elements from the BAF and the integrated quality report. So just a reminder about how we're using these 2 primary documents to have that kind of rounded discussion. Thank you.
To build on that, the first session is on we are delivering high quality care. In a moment I'll ask Liz to give an update on the most recent meeting of the Quality and Patient Safety Committee. Then there'll be an opportunity for the clinical leads in the executive team, Richard, Joe and Jackie, to give any comments that they want. I will then open it for general discussion. And then finally, we have a question from a member of the public that Richard will respond to. So that's the first element of this particular pillar. So Liz, can I ask you to give us an update from your Quality Committee, please?
Thanks, Chair. Quality Committee met 2 weeks ago, so you have the paper in front of you. I hope you will now start seeing threads from what we've been talking about previously going through this quality report. So the cycle of business, the terms of reference and cycle of business were agreed, which aligns to the BAF, and it will be dynamic. It isn't set in stone. We will amend it as the risk profile changes within the year, and the board is asked to formally approve these documents. In terms of the risk report, there was good alignment of the risks. We challenge, there is some cleansing of the risk register required, which is being undertaken in Q1, so that will be tidied up. There was some out-of-date actions, etc. The committee also reflected, whilst there is good assurance, the risk register is increasingly driving the focus of the trust through its governance structures, and therefore the right discussions to inform decisions are being had. But there is inconsistent discipline in updating the risk register. So we wanted assurance that actions were closed and had moved forward. It was great to hear from Ruby, the head of risk, confirming how proactively, and I think it leads to what we've discussed with the CQC, the new divisional leadership teams are reaching out to improve and support the risk discussions at a divisional level and how those discussions are taking place. I think there was a potential gap in assurance around the robustness of risk sharing of services that are subcontracted, but we will pick that up at the Audit and Risk Committee, separate to that. One of the big priorities was around virtual care, in terms of our concerns around the delivery of Hear and Treat and the expectations of achieving those targets. I think there was a fair challenge back from the committee along this, and we're very aware that the executive are working hard and rapidly to improve the trajectory. We are behind our target at the moment, but we have to recognise that from our patients' perspective, we have one of the best C2 response times in the country. So I think recognition of that the fact we are not achieving our Hear and Treat at the moment is not impacting the delivery of our C2 response. We were informed that the exec has got weekly productivity meetings set up as check and challenge, which is helpful. They have identified barriers, and staff are asking for more training, mentoring, support, and I think Jen mentioned that earlier, and that the executive were more confident of the actions of the here and now, and they can demonstrate really strong partnership working between paramedicine and ops. Recruitment is ongoing. We did express concerns around the workforce plan for this. There have been 37 internal applications for virtual care roles. We need 100, and those applications are people and staff willing to move from field ops to virtual care hubs, and it's great it was discussed at the Shadow Board as well. I think we challenged the timeline of the workforce model in context of virtual care, Hear and Treat being the highest BAF risk and corporate risk, and our main strategic priority this financial year. And we acknowledge the amount of thinking and actions that's been applied to the challenge. There was a workshop earlier this week by the exec, and that will come back to the next QPSC and scheduled for the board in August. Pathways of care, just to say there's a change of language, and I'll get Richard and Jackie to comment on this. Previously, we've spoken about models of care. We felt it was a more appropriate language, both from an NHS perspective and clinician and patient perspective, that we talk about pathways. A model of care doesn't really mean very much, whereas most people nowadays understand a care pathway. And that's aligned to the language that SCAS use. So this has been reshaped into the BAF, and the committee reviewed the aims and key milestones for the year and in the risk as well, and boarding on the part 2 discussions in April with the ICB. So great news, the 11 pathways have been adopted by SCAS, and we're aligning the work with them, including the metrics, which is great to see, and huge progress. And the committee is assured by the rigour behind this and the level of input from clinicians. We explored engagement with commissioners, and we already mentioned that earlier around end-of-life care delivery, similar for mental health, etc. And the training packages being put in place to upskill our clinicians. In terms of framing, the changes we're focusing on is priority about using our resources to best meet the needs of our patients that really require our support, and hence that major shift to that virtual care here and treat options. Another great area of good news was on our shared care records, which is really important as our clinicians see our patients. It's being rolled out this year. It went live from April in Ashford, which is fantastic news, and there is then a phased rollout plan, and we've asked for confirmation of the dates of that at our next QPSC. And then obviously we've already mentioned the joint clinical operating model. There's also a lot of work going on in terms of the patient and public voice work that was presented to the committee, compliance around our IPC, and the integrated patient care report is there for you to see. Happy to take any questions, but also for Joe, Richard, and Jackie to comment on the feedback as well. Thank you.
Thank you, Liz. That was really tour de force in detail, and so thank you. I'm very assured by the work that you're doing. I would like to ask, I don't know how you want to do it, Jackie and Joe and Richard. And may I ask one question that is more relevant, I think, in the current position, given the incredible heat that we've had over the last week or so. Do you want to say something about our ability to maintain services? Has that been an impact? Because members of the public, that's a general question that's been going in the media more generally, and I just think it would be helpful if we could just touch on that, but also to build on Liz's excellent report as well, please.
Yes, thank you. So in terms of responding during times when we are pressured, so we did see demand go up significantly during the hot weather. All ambulance services, all NHS services saw that increase. And when we're in those situations, we've got well rehearsed and developed and approved plans in place to manage the increased demand. So we have a clinical safety plan which enables us to undertake sequentially actions to make sure that we are in the best position to respond as quickly as possible to the highest acuity patients. So we take a number of actions to make sure that we protect our capacity for the patients who are most at risk. One of the challenges with the hot weather is, apart from kind of the obvious new demands that we might get, is the hot weather can have some quite significant impacts on patients with chronic diseases and their ability to self-maintain their conditions. Hot weather also can have some interesting interactions with some of the medications which people take. So we respond to that in a way by developing our escalation, but also there is important work to support that within the wider system in helping people to be prepared for those changes in the weather as well. Whilst I've got the mic on, can I just alert the board to the really good news in the cardiac arrest survival at 30 days as well. So we're reporting now for December last year, and often in December as part of the winter period we can see our cardiac arrest survival from all causes at 30 days go down. We were at 12.4% in December, which is absolutely fantastic. We're at the top of the leaderboard for the nation, but we are over a percentage above our next nearest neighbour and more than 3.4% over the national average. So I just wanted to highlight that we're seeing really, really good survival as a result of our continued attention in that area as well.
Thanks, Jackie. That is really, really excellent, and it's all about what we're here for: better care for patients and outcomes. So thank you for that, Joe, and then Richard. Or I don't know how you want to do it, Richard.
Yeah, thank you. Just to come in quickly on the increased demand during the hot weather and bank holiday weekend, just to provide some assurance, Jackie spoke about the clinical safety plan and our different levels of intervention dependent on the demand that we're seeing. We do have a process in place, an established process that when we enter CSP4, which is our highest level of intervention, we complete a proactive harm review. So that is currently being undertaken by the quality team following the bank holiday weekend. And that allows us to proactively identify areas for opportunity and what we might need to change in subsequent times of high demand in the future, and also helps us to really establish what the impact of that was on our patients and members of the public. And just secondly, in following on, in follow-up to Liz's report, I think the area for focus for the board for me is on patient and public engagement. And just to reiterate what everyone already knows, that this isn't a nice to have, it's a prerequisite for effectively delivering on our trust strategy. We've done a huge amount of work in this area over the past couple of years and have extensive plans through our patient and public engagement strategy to increase that. And I would recommend that the board has an intentional sort of oversight of that as we move forward, particularly in view of the changes nationally and a reduction in some of the quangos. So we don't have Health Watch, for example. They will be reducing like we used to have, who perform some of those roles on our behalf.
May I ask, drawing on this, and I will open it up. It came up at the meet the chief with Janet Chertsey, which is it is clear that when a member of the public contact us, often they are naturally very concerned about their health and the outcome and the support that we can provide. But it is clear that an ambulance is often not the best solution for them. So there's this whole issue around, in the best possible way, engaging with the public to help them understand what is the best outcome. And I believe that ACE are doing some national work in this space. It's not just us; it's a UK issue. So I think we have to be very mindful of how we get into that space. So I very much support what you're saying. Thank you, Richard. Please.
Thanks, Chair. The only additional thing I would add is that in regard to Liz's report to Quality Committee around from Quality Committee around the joint clinical model with SCAS, is that linked with the clinical restructure in the organisation, we're soon to have a new team of area clinical leads in post from July. And each one of them will have a trust-wide role in terms of leading one of the 11 pathways. So that totally integrates our new operational structure, clinical leadership structure with our clinical strategy model. And what will be really exciting is they will then partner with the pathway leads in SCAS. So I'll have someone in SCAS who's leading the pathway in that trust, and that will be a very strong partnership. So yeah, lots to look forward to, and we'll be able to update against that at the next board as those people come into post as ACLs.
Thanks, Richard. Really, really encouraging about the joint work. Karen, I believe you had a question, please. Thank you.
Yes, thank you. And just building on some of Liz's comments, I think one of the things that has come up in a number of these subcommittees is the implementation of the new divisional structures. And I had the pleasure of attending one of the divisional clinical governance groups, is that what you call them, if I got that right, at Ashford. And it's nice to see those beginning to kick in. My question really to the executive is around how you see those developing. What do you think the biggest challenges are at the moment to getting those up and running? And what do you think will be the benefits as a consequence of taking this forward? Thank you.
I think we can all answer this. So I think firstly, I think the huge benefits is being able to have that population neighbourhood-based approach. When you spoke earlier around the emphasis on health inequalities and other things, those are the things that we can really look at in that divisional way, and it supports the working of the teams to work in that divisional way. I think some of the challenges currently are probably around the discussion of what level of variation is expected, and we talk quite often about sort of we want individualized population-based care, but we don't want unwarranted variation. But I think we're still trying to ascertain what does that actually mean, what does unwarranted variation look like. We expect all the divisions to work differently, but within what parameters would that be acceptable? So I think for us, that's a work in progress and something that we're beginning to really grapple with and develop, and will continue over the coming months.
If I can come in as well on that, so we're taking a very deliberate triumvirate approach to governance from the perspective of having the different voices and lenses available to us. So one of the things that we're particularly focusing on at the moment is we've got some of the structures and processes in place, and how we now within those teams support people to really show their working, particularly as the reports come through the governance chain, so that we can move increasingly from something that might sometimes feel more like reassurance to assurance in terms of the triangulation of the data that they're able to work with, and there is a piece of work ongoing to make sure that they've got access to the right data, and then triangulate that information with the qualitative information that they're picking up from sort of being on the ground and around and about on walkabouts as well. So we're sort of moving into that, what we do with the processes much more deliberately, and showing our working in that space as well.
I open the floor to any other questions of Liz. I've got one at the very end, but I'll open it first for other colleagues. Okay, my question, I don't know, Jen or who wants to answer this. So what we've heard this morning is that we've still got some way to go with Hear and Treat. Interesting what you said about there were only 37 applications. Jen, you and I, we had a discussion with colleagues at Chertsey, it came up. So, you know, I wouldn't be doing my job if I didn't ask the fundamental question. You're doing a lot to try and sort this out. What's your current prediction of when we think we're going to get traction on this? And I know it's difficult, but I do think it's so key as well to our financial performance, isn't it, Simon, on that base? And yet there seems to be, and this is not a criticism, I know everybody's working very hard, but what's your idea about where we're going to be in August or July?
Shall I come in, Michael?
Please.
We did have a really helpful discussion about this yesterday at the executive workshop that Liz mentioned. I think acknowledging all of the effort that's been put into improving the virtual care Hear and Treat position over the last 18 months, and we haven't not moved at all. There has been progress, but I think the key issue is the productivity, effectiveness and outcome of the work has not been at the pace and scale that we require to deliver our strategy and to make a sort of step change in the way that we deliver our services. And it's that step change that we're now looking to enact over, I would say, the next 6 to 9 months. So our aim is to improve continuously here and now to support our ability to meet our performance and financial plan. But actually, we'll recall that we signed off a new future model of virtual care at board quite recently, and we're now in the implementation period of that in order to support that kind of next step change in our delivery of virtual care. And the current plans, as you said, Michael, will be updated on in board in the next couple of months, but we'll be looking to make significant changes in the workforce structure and sort of training, governance and outcome in that new model over the next 6 months, and be seeing the impact of that by the end of the year. So we need to accelerate the work that we're doing to make that change of model while maintaining continuous improvement and output for our patients. So that's really the conundrum, to continue to deliver here and now, to keep people on board with the way that we're delivering virtual care at the moment, and to optimise the contribution that we can make over the next, say, 6 months in support of delivering our plan, while also managing significant change in the model to deliver the future model that will enable us to scale up. So that's a challenge we discussed yesterday. I think we particularly echoed the points that have been made about the workforce, and really this new model helping us to reframe and publicise, celebrate and embed roles which are, as I think Subo said, an equal and equally valued part of our workforce in virtual care, and in a kind of inclusive way of different multidisciplinary skill sets, different ways of working. So that, I think, is the critical challenge which we're going to prioritise.
I'm generally encouraged by all that, but what my challenge to this is that there's a number of variables at stake here, and if we don't get traction by, I would assume, Simon, by September at the latest, we're not going to get some of the productivity, and this is quite a conundrum for you and the organisation as a whole. And all I'm just saying, my question is, I'd be looking for a critical path with key milestones that could come back to this board if we can't meet those milestones, and what are the consequences. I'm not sure, is that critical path available to FIC or the Quality and Patient Committee? It needs to be reviewed fairly regularly by one of the committees, I think. But it's an open question. Sorry, yeah.
Yeah, we do have a critical path, and we have shared it here in terms of this financial year. We are coming up to a key sort of milestone on that critical path. So on the 17th of this month, and we did some preparatory work, as Jen mentioned yesterday, in execs. On the 17th, we're going to come back and say, are we where we need to be for this year to avoid having to make any more significant changes now to impact Q1 of 27-28. So it's, from a financial point of view, it's the balance of non-recurrent and recurrent cost that we need to bear in mind. As board will know, we started this year with a recurrent underlying deficit just under 10 million. Our 3-year plan will recover that position to balance. So it's how we do that balance between recurrent and non-recurrent, I think. So key decision point coming up on the 17th, we'll be taking a look at all of the programmes of change that we've got on the docket, and for each one there will be quite a clear bit of scrutiny around where are we, where do we need to be.
My question, sorry, and I wasn't clear, is I've confidence you do that. It seems to me one of the critical drivers is virtual care, and what we've heard is that there are multiple variables here that we've got to manage and control. And I think there is a critical path for managing those, particularly in the context of Human Tree. But I just want, it's my final board here, I just want to leave with the assurance that is being clearly looked at by each committee, and that the board is not placed with a position that we get to September and there's nothing we can do. And I'm not saying that's your intention, but I think we need some transparency on this. But Liz, I don't know if you. Thank you.
I think also to reiterate, CCAM isn't the only trust struggling with this. I think across England, all the trusts, and in terms of the 10-year plan, that rapid movement to virtual care, hear and treat, also whilst maintaining C1, C2 response times, which we are doing. So it's balancing that with a clear plan that we are progressing and improving those rates and the service we continue to offer to our patients. So it is a fine balancing act, and across multiple committees.
Yeah, so I'd agree that virtual care is probably the single biggest thing. So that's clearly something we need to focus on. But as Liz has just said, C2 is behind trajectory. £5 million of income this year will be coming to us or not, as judged by our adherence to trajectory in October. So that's a big thing we need to do. Virtual care is a big thing we need to do. Some of our terms and conditions discussions with our people that we need to land this year are also big. So there's probably 3 or 4 really key things that we need to be cited on that we're sticking to the plan. And if we're not sticking to the plan, have we got actions that will get us back to plan? And if not, what do we do then?
Yeah.
So we've got all of that covered. What we need to do through June and July is decide whether or not the actions we've got tabled will do the trick and we've got confidence in them, or do we need to go to plan B?
That's a better articulation. That's what I'm really looking for. And my advice would be, it's not my call. I think that should come back to the board in August, where you can actually, you don't want to get to September mid-year points and you're running out of space to make any changes that you need to. So, I mean, it's for my successor and Jen to decide, but I think that needs transparency going forward. And that's not to say that you wouldn't provide it, but I just want to put that marker down that we need to be really, really on this and we manage expectations. But thank you for that anyway. Thank you. Please, thank you.
Thanks, Chair. I don't know if you want me to keep this question for the finance section, but Simon, it's interesting when I look at the BAF, you've scored cost improvement as 16 less, and the virtual care model is 20. Just in light of this discussion about Here and Treat, and I had the similar sort of concern about us not being able to hit 17, but you've put in the BAF, I think, that you want to hit 19. And then I think you also say something about the backup, which I assume is the backup plan, which is to do some restructuring to save 10%. So I suppose my question is the BAF score a bit low? Should it be higher to match the virtual care model?
So no, I think, would be my judgment, because I think if we get the virtual care right, which is our biggest concern across the organisation at the moment, then the finance, if you like, will follow where it needs to. So I think the sequence of actions and the relative risk we've given to each one is correct. Also, what would happen if virtual care didn't deliver? There are things we can do in finance that we could bring into the mix that are independent of virtual care. So that again is a factor in how we've ranked them. But it is one of the most significant risks in the organisation.
Okay, I think that's a good discussion. And as a board, I would recommend you need to, well, you know this, you need to return to this going forward. Can we move on to, I think there was a question from them. Oh, please, yes, sorry, Suzanne, not seeing you, I do apologise. Please, ask your question.
No, it's not a question, Michael, really, but it's just to give some, because I appreciate, this is all integrated, and just to reassure you that we have covered this off at the Finance and Investment Committee. So, and as Simon has alluded to, absolutely Here and Treat, virtual care, this has gotten a lot of airing so far on the board. We're also minded on fleet optimization and reducing abstractions. As those 4, if you want, were the ones that have been articulated as the productivity programs. So we're absolutely fully cited on that. And the risks, we had a substantial session in the Finance and Investment Committee, not the one just past, the one previously, around the risks and the risk rating. But I'm happy to pick it up and give a fuller answer when we get to my section of the agenda, or I'm happy to go further here if you think it's more appropriate in the context of where the discussion has gone.
Firstly, Suzanne, I'm sorry that the nature of the discussion is free flowing, so I'm sorry it's not in the right sequence, and I'm absolute confidence. I know you're on this. May I ask if you would prevail, and we'll come to it when we come to the Finance and Investment Committee report, where I'd like to go in a bit more detail as you've alluded to. But thank you for your intervention at this point. But thank you. And Richard, would you like to deal with, I think we have a question from a member of the public. Do you want to?
Yeah, no, just before we get to that, can I just record for the minute that the board's approved the terms of reference and the cycle of business for the Quality Committee?
Yes, sorry. Thank you. Yes, please, Richard, thank you.
Thanks, Chair. So we've had a question from a member of the public which is asking us whether we use pre-hospital video triage as part of our suspected stroke pathway. The simple answer is that yes, we do use pre-hospital video triage, apart from in two areas, which is Maidstone and Tunbridge Wells Hospital and the Royal Surrey Hospital, where we haven't introduced the pre-hospital video triage pathway with those two particular hospitals yet, but the rest of the trust, we are using it, and we're in conversations with those two hospitals about introducing it for those areas for the future.
Okay, thank you, Richard, for that answer. And also, thank you to the member of the public who asked that question. We are a board meeting in public, and it is good that members of the public ask questions of us. So thank you, whoever you are, for doing that. And I hope the answer is clear for you. Thank you. If we could now go on to, and then we will have a break, we have the Patient Safety Incident Response Plan. We had a lot of discussion about that at the previous board, really excellent with Kenny there. But Jo, do you want to, this is now from formal approval, isn't it, I think?
Yes, it is. Thank you. So I'm excited to be introducing the Patient Safety Incident Response Plan for 2026-27. A lot of work has been done, as you identified, Michael, by Kenny, who is our Safety Improvement Specialist, and the wider patient safety team. This sets out how we will respond as a trust to patient safety incidents over the next 18 months, building on what we've learned from the previous plan. And I think the previous plan was our first plan as we moved into PISA from the previous SI framework that was the national approach to patient safety incidents. And we're now in the process. The first plan was very much about getting the foundations right and the processes in place. We're now moving beyond that about how those processes actually lead to real improvements for patients. We identified very clearly at our board development session that behind every incident is a patient and a family, and we heard a very emotive patient story there. And how we respond to those patient safety incidents really matters, whether we involve those patients and families properly, whether we truly understand what happened, and whether we can make those meaningful changes as a result. So this plan sets out 3 priorities which have been chosen based on analysis of data, stakeholder input, and alignment with the trust strategy and other priorities across the organisation. And they are mental health, major trauma, and transfer of care. The main shift in this PISA that I want you to be aware of compared to the last is the need now to focus on that impact, but also proportionality. We know it's not enough to just investigate incidents and generate actions. We need to be confident that those actions are translating into safer, higher quality care for our patients. And also, we are having conversations about where we make intentional decisions to investigate certain incidents based on that proportionality conversation and where we can really make a difference. The plan introduces a more structured approach to tracking actions and testing when they're working to determine whether we've made the improvements that we set out to do. The plan recognises what we already know across the organisation, that safety is closely linked to culture, leading into obviously the work that Jackie's done around the leadership framework. We know that if staff don't feel safe or able to speak up, we won't get the learning that we need. So improving psychological safety remains an ongoing consideration and focus of the plan. The board is asked to approve the plan and maintain a clear line of sight on patient safety, really asking the question, are we truly learning, and whether that learning is actually making a difference to the care that our patients receive. Thank you.
Thank you, Jo. As I said, for members of the public, we had a considerable debate and discussion around this plan and help shape it as a board. But the question now is, are we happy to approve the plan? Yes? Okay. So very pleased to approve the plan, and thank you and your colleagues for all the work that has been done, and obviously that will be continued to be monitored by, I presume, Liz, your committee? Yeah. Yep, that's great. Okay, thank you, colleagues. Running a little bit behind schedule, but we will catch up. I propose that we have a 10-minute break now, if we could reconvene at 5 to 12. Thank you very much. Thank you. Good. Thank you for everybody coming back. We now turn to the item on the agenda, which is about our people and our confidence that our people are looked after and well supported. And Harbhajan, as chair of the People Committee, may I ask you to give your summary, please? Thank you.
Thank you. First of all, hopefully people have had a chance to read the report, and it is fairly comprehensive, so I'm not going to necessarily go into too much detail, but maybe just open it up for questions. A couple of things, just using the sort of alert, assure, advise methodology. The terms of reference and cycle of business were presented, and basically both the board are asked to formally approve the People Committee terms of reference, which were revised, and also the People Committee cycle of business for the year going forward. So hopefully those are two things that we want to do. In terms of, we had a conversation looking at the organisational operating model, had a report back, sort of a closure report looking at the activities for last year, and also looking in terms of the key milestones that we were going to sort of focus in on around 26, 27, and those are all, obviously all set out in the new BAF. One of the areas that we did sort of have a little bit more of a conversation around the corporate restructure was actually one of the areas we do need to focus in on, Nick, is around the digital team, so that's something that is there. Within the clinical operating model, obviously the move to divisions, one of the key areas is about strengthening the governance arrangements, and that ties back into some of the earlier conversations we've had around leadership, etc. So in terms of that area, fundamentally, it is about actually ensuring that we strike the right balance between making the changes and making sure that we take our people along with us. That's always a really, really difficult thing to do. So the plan itself is pretty challenging, but certainly through the conversations we had, the belief was it is definitely achievable, and it is also necessary. Some of those key changes we do definitely need to make. There were concerns around our capacity given the volume of change, so because there is a lot going on at the same time, there was conversation around the capacity within the people team itself as well. So those are conversations we will continue to have as we begin to sort of have meetings going forward. We also had quite a good look at the leadership development framework, and the draft was reviewed, and certainly the People Committee have recommended to the board for approval. It was really emphasised that it is a framework for all leaders, and not necessarily just for senior leaders, because that's obviously quite often one of the conversations we have. The key to this is around the implementation, and one of the areas we wanted to really sort of focus in on is how do we approach first-line managers, because actually they're quite key players in terms of actually how the organisation culture is shaped and begins to move in the right direction. The other strategic priority is obviously the workforce model, and the committee noted the work around the interface with the virtual care programme, and which will sort of define the virtual care skill mix, workforce needs. But when you do pieces of work around that, people are obviously, and we were just having that conversation, people will think about actually what's a career pathway if I'm going into that particular area, where do I go next, what are the skills I'm going to try and pick up. Around Assure, we had a couple of reports. One was around the education quality inspection, and the next review with NHS England is due on the 11th of June. But again, good progress was being made against the mandatory requirements. And one of the key things actually that was emphasised in the paper is that this is something that's ongoing. It's not a one-off fix. We will need to constantly go back and have a look at that. We also looked at progress being made to implement the NHS Safer Learning Environment Charter. And again, assurance is supported by, and I won't go through all the bullet points in the paper, but again, that was being provided in terms of foundations, learner voices being listened to, etc. In terms of advice, it's the risk report we did look at. We believe that there was a good visibility of risks. The committee did focus in on a gap in assurance reported previously related to fire risk assessments, and that's been picked up through the Finance and Investment Committee. We did also, in terms of looking at the data, explore the risk absence, sickness absence, and whilst there's a new management attendance policy going live in June with training sessions, we did ask that actually further information around assurance on the management of sickness, particularly long-term cases, is provided to us. We know, and certainly when you look at data nationally, actually the picture within the NHS is going in the wrong direction. If we look against the cost of sickness absence to the NHS is over 5 billion now. Average sickness absence in the private sector is about 1.4 days, whereas actually we are significantly above that. So there is something that we do need to think about and focus in on. From the IQR, we also looked at the high number of grievances, and whilst we could see improvements in terms of actually managing those, and it was really good to see the informal resolution policy in place, and so things aren't going formal. The earlier you can have those conversations, the sooner you're able to address that. One of the metrics we did look at is the mean suspension metric still being too high, and we had a little bit of a conversation about why, and about being a little bit more proactive around sort of, quite often we get advice, for example, if a matter is being dealt with by the police, they say don't do anything, and our view is to be able to try and push that and be able to make some clear decisions. It was encouraging to see appraisal and Statman going in the right direction, because again, that for us is quite one of the key indicators of good leadership. And we also received the comms and engagement and recognition dashboard, which was really welcomed, and so it gave us confidence that actually that there was a plan in place to be able to sort of really see feedback from things like the staff survey, not just being a one-off, just before you do a survey, suddenly you said we did, but it's a continuous plan in terms of trying to engage. And so that then ties on to the staff survey section. We also received an update in terms of the National Education Training Survey. And whilst there were positive bits to it, there were a couple of areas of real concern, and those were regarding reporting rates for bullying and discrimination, as well as specific sexual safety challenges, which again are built into the plan. So they are things that we are listening to and we will sort of look to be able to address. And so whilst most students reported knowing how to raise a concern, it was about actually the hesitancy to do so, and that quite often is an issue about power imbalance, the individuals being able to influence where, in terms of my reports, my career progression, and that's something we will need to find better ways to be able to address. We also need to be able to give confidence to people that when they are raising concerns, that those concerns will be properly looked into. And so one of the things we've talked about is how do we feed back on the back end of some of the investigations that we're undertaking. So it was quite a full-on meeting covering quite a large number of areas. So I'm going to just open it up to the group.
Incredibly impressive what you covered. Just something that you said there. I mean, the power imbalance is so important to address. I just wonder, you've got a lot of experience in the NHS acute sector. Do you observe fundamental differences in the ambulance sector, or is it? They often talk about there's more of a hierarchy, but there is a hierarchy in the acute sector. I'm just interesting as a general observation.
No, I think it's an issue for all organisations, so it's not necessarily specifically to the ambulance service. I think the difference here is some of our sites are smaller.
Okay.
And therefore actually the visibility of some of the behaviours can be more hidden, and that's something that we do need to think about and look at.
Yeah.
So, you know, last place where I worked, St George's, we were
Yeah.
predominantly one site,
Yeah.
and therefore actually some of those behaviours were more easily seen. And so that's again something that we do need to think about. Again, it's about making sure that through our comms, through our constant engagement with staff, that we're actually giving them assurance. So, you know, where, for example, there are cases of bullying, harassment, sexual safety, I think we need to be a little bit more proactive to say, you know, we've investigated it and these are the actions we've taken, which is something that the Trust has done over the last year or so. And that gives people confidence to be able to come forward. It's no different with junior doctors, for example. Junior doctors won't report when they're being asked to do excessive hours.
No.
Because they will tell you the consultant is the person who will then shape their next career move. So it's not unusual, but I think it can be more hidden here. I think that's probably the thing I would say.
That's really insightful. Thank you for that. May I ask Sarah and Jackie, do you want to respond? Any questions or any you would like to add to that?
Thanks, Michael. So, thank you, Harbhajan, a very comprehensive overview there. So I think from my perspective, just in terms of some of the metrics and the oversight, I think the progress we have made is in terms of understanding from the sort of live employment relations dashboard that is now available to each of the divisional teams. So there's a lot of work now happening for them to be able to review things like the sickness figures, the number of grievances, the different issues that are picked up. And I think in terms of that sort of oversight, that will be really helpful for us to be able to monitor what the issues are and also how our local sort of policies, because we put in 3 new core policies around a new managing conduct policy, the resolution policy and the managing attendance policy. And I think through those, that will be about how the local leadership respond to those policies. So we're spending quite a lot of time at the moment in our people services team, training the managers and leaders in those policies. And what we expect to see over time is more local resolution of issues and better resolution of issues, and also that confidence around speaking up. So I think I just wanted to highlight that and the importance of the People Committee giving that sort of oversight and assurance. And it was a really helpful discussion we had at People Committee to do that. Thank you.
Thank you. Jackie, anything you'd like to?
Thank you. A very, very comprehensive summary. Sadly, I wasn't able to attend the meeting, but it sounds like one of the best people committees that we've had for a while, possibly. I think specifically in terms of some of the issues in the NET survey from students that you've touched on there. I think for me the devil really is in keeping consistent and holding our nerve on reflecting back to the organisation and the people within it, the steps that we have taken, particularly following the events of late last year, and what I think some of our learners and our workforce expected us to do in response to some concerns that were raised, and actually kind of us fulfilling what we should have done in those circumstances. So I think there's probably a role now for us to consistently continue to play back the action that we are prepared to take, just to complete reinforcing that we're in a different position in relation to those things that as situations continue to arise when they do.
Thank you. Support what you're saying, that our people need to see that we take concerns seriously and take action. May I open it to question, Harbhajan, and then Peter, and then
just on the back. I mean, some of the issues that have been identified in the NET survey results are not unique to us either.
No.
And so when you do look at the national position, actually some of those issues are something that actually I think does, we do need to think about actually how do we pick up. We need to make sure it doesn't occur here, but it's something we also need to be thinking about picking up at a national level, because I think there is something about students not being able to, or feel that it's worrying that it's across a number of different organisations, but what's also stopping them, and what are the sort of tutors also doing with their students as well as us in terms of when they're with us, to be able to give them that confidence and give them those different routes to be able to report in.
not to sidetrack, because I do want to open it. It's something that has bothered me, not bothered me, that so I come from a financial services background where you train graduates every year and school leavers. You know, the numbers are going down now, but you can contrast with PwC, and Peter will know this, you know, in tens of thousands globally. My own organisation, it was 150 a year. The really important thing is that as a member of that organisation, you feel valued because you know you're the intellectual capital of the future, but also that that there were two lines of reporting. It wasn't just to your line manager who could control everything about your future. You had your development director and your development manager, and they were there to make sure that you know that you were looked after from a completely different perspective. And it was a win-win for the organisation because you want to get as many people through and as many people on your career progression as you can. And I still struggle. I mean, from the limited experience I've had of even hospital doctor training, I don't think that distinction is made very, very clearly. And also the role of the colleges doesn't always come through as well as it should. It's a bit messy. That's just an outsider looking in, actually. So please, I mention your response because we could debate this.
I mean,
yeah.
The PwC one example will be because it's PwC as a single entity, whereas actually we're working with a number of different entities. Each university has its slightly different approach. So it's more of a complex
I accept
ground, you know, and then there are inputs certainly for doctors in training, you know, the colleges have a role to play, etc. So, but it should be actually, they should have numerous different routes to be able to raise concerns. And the issue here is that actually part of it is it's not having the confidence to be able to
do it.
Raise it, or any belief that actually something will be done with it. And that's why I think the whole conversation around data is really critical, because actually that will enable us to be able to say, if you don't come forward, sometimes it's very difficult for us to do anything, but if you do come forward, then we can actually show you that actually this is how quickly we've dealt with it and this is the potential outcome. And sometimes publishing those is also incredibly helpful.
You know, really excellent. And one thing, so, and all of you, my reflection is that we are having these conversations now, which I don't think we were having years ago, and I would hope that people watching in, if they are watching on this, would see that the board is taking this seriously. So thank you. But Peter, you waited, please. Thank you.
Yeah, I still think there's an opportunity for an L&D manager within our organisation to help in this. Because that would be helpful. My question really was around whether or not the People Committee sort of touched on this, SCAS, CCAM, collaborative working and the group model. The reason I say that is I spent yesterday at Kingston Hospital and as I was walking about were CCAM ambulances, so I pressed the flash and said hi. And one of the things that came up in the conversations with the paramedics there was, are we part of the new group model? We're getting a new chairman, we're getting a new chief executive. So there was excitement, also they were inquisitive around it as well. And I just wondered whether or not that is something we need to think about and talk about as we move forward. I don't know, but people are clearly interested.
It's good that interest there. Sarah, did you want to say, or Jackie on this one?
Yes, Peter, it's certainly a live conversation, I would say, in terms of, you know, our approach around the collaboration and the group model. So it's something that we have got on our risk register that we are sort of monitoring, but certainly it's something that we're working with SCAS to think about, you know, how do we approach our leadership offer, things like the leadership framework, you know, is that something that we could share with SCAS, for example, you know, to look at how we embed that, how we implement that together. So it's certainly something that, you know, we are consistently checking, challenging ourselves and thinking about how we work with SCAS colleagues on, you know, things like that to actually share that learning, share good practice in that way.
That's really encouraging and that's really important as well. So thank you very much for your comprehensive answer, both of you.
Sorry, Just a couple of quick comments, if I may. One, just picking up the point about students raising concerns. It's probably also worth saying, talking here about the fact, something else we talked about in the meeting around that isn't just individual students. There's something about organisation to organisation and the relationships between them. And I think the work that's going on has identified that some of our relationships with some universities is better or worse than others. And I know that has been raised at board before. I think work is going on. We took reassurance from the fact that has been attempted to rebuild some of those relationships, because that is critical as well. So at a strategic level, I think we took some reassurance, but recognising there's some work to be done in there. The other point about the group model, I think I'm noticing, and certainly it came up at the Shadow Board, didn't it, around, what does this mean for us? And so I think some of the messages that I think people are finding helpful is that there's almost like an expectation, tell us what it is and what it's going to look like. And I think my understanding of the way that we're going to be taking this forward is through engaging with the people that are going to be involved. And I think doing that, but of course that creates a certain sense of uncertainty because there isn't a nice organogram showing where people are going to fit in. So I think once we start scheduling some of that work and getting into some of the more detailed discussions, as we have, for example, on things like the CAD, then hopefully we can get people's views on that. Thank you.
Thanks, Karen. Harbhajan, please.
There is already a lot of good work in terms of collaboration going on, and it's not necessarily just on the 5 key priorities that we've identified formally. A lot of that one-to-one relationship, people are actually already reaching across both organisations to be able to say, who's my counterpart and how can we have conversations, whether it's in comms, whether it's in terms of freedom to speak up. So all of those things are really positive. I think there is something about people wanting to know what the end goal is. And at the present moment, I think it's going to be up for a lot of conversations. And so it's not something that's going to happen immediately. But I think the collaboration pieces can start moving at a pace, because the key to this is actually there are some things one organisation does better than the other, so we should be taking the best of those and just continuously thinking about how we develop that. I think certainly a lot of the directors are meeting each other as well, and so I'm having a conversation about whether actually the 3 of us, 2 chief people officers and myself, meet on a regular basis, because that'll be a positive way of sort of just making sure that actually, even in terms of how we work around governance, and I know sort of a lot of those conversations are going. So I think there's going to be quite a big, people are going to look towards Colin and say, what's the answer? And I don't think, he will tell you, actually, he's something that he'll want to develop with us as a collective. So if people's expectation is something's going to happen overnight, I think that's a big, we're going to have to manage that, yeah.
I think that's very wise, and you're quite right. I mean, I've spoken to Colin. You design that together. That's what the aim should be. So yeah, no, I think it's very well said. But you've got to manage that expectations, because often people want to know, don't they? Yeah, I know actually. Thank you. Okay, that was a good discussion. Can I take it as read that the terms of reference for the People Committee are approved? I'm taking that as read as such. I think we have 2 questions from members of the public that, Jackie, you're kindly going to answer, and then we'll go on to the leadership framework.
We always do that at least once in a meeting. Apologies. So we have 2 questions from members of the public. The first one is in relation to, they're both in relation to NQP recruitment and workforce planning. So the question is, there appears to have been a significant reduction in newly qualified paramedic recruitment at a time when ambulance services nationally continue to report workforce shortages, increasing demand and ongoing operational pressures. So given this, could the Trust clarify how the current restrictions on NQP recruitment fits within CCAM's longer term workforce strategy and future frontline staffing requirements? It would also be helpful to understand whether the current restrictions are expected to continue, whether the position is primarily driven by funding pressures, establishment caps, supervision capacity, or wider workforce planning considerations, and what the anticipated outlook is for future recruitment activity. So in response to that question, there is a national shortage of NQP roles at the moment, and there is an oversupply of newly qualified paramedics which has been developing over the last sort of 12 to 18 months or so. So there's a proportion of graduates last year that were unable to secure employment due to a lack of available roles, and overall UK ambulance services this year are recruiting fewer NQPs than they have done in previous years, where there have been a greater number of paramedic vacancies than qualified paramedics qualifying or returning to practice. And unfortunately last year, whilst there was a graduate guarantee which was offered to some clinical graduates, paramedics and other AHPs weren't included in that last academic year. There has been a significant expansion of pre-registration programmes in the UK over the last few years, but that's been without equivalent growth in entry-level positions, so this has created a gap between supply and demand. And alongside this, there has been slowed progression into advanced practice roles and roles outside the ambulance service, for example, in primary care, and some of that is linked to changes in broader NHS funding mechanisms such as the ARRSR's funding mechanism, and that has changed the workforce profiles in terms of sort of career flow. Over the last few years, we've been working actually very hard to fulfil paramedic vacancies with the intention of achieving safe staffing levels, and alongside that we have also seen quite a significant slowdown in attrition. So consequently we currently don't have any recruitment, any paramedic vacancies to recruit into. In the past we've taken an approach to do sort of bulk recruitment, so it's the bulk recruitment that we're not able to do this year rather than us having a recruitment freeze on vacancies. So from a longer term workforce perspective, we are, as we've heard earlier, developing our virtual care workforce, so that's roles for experienced clinicians including paramedics who will work both on ambulances seeing patients face to face as well as in our contact centres. So NQPs do continue to be a very important part of our workforce, but there's an example there of how we need to fulfil other roles to create the vacancies kind of behind for people to move into when they're available. Happy for me to move on to the second question. So the second question specifically, it's in the same vein but relates to internal progression for existing CCAM staff in this space. So we'd be also be grateful if the Trust could clarify why existing CCAM employees working within operational roles such as emergency care support worker are not able to transition directly into NQP positions after successfully completing recognised degree programmes, particularly when we have a pathway already operating for apprentice paramedics moving into qualified paramedic roles. Many of these individuals are already embedded in the Trust operationally, are familiar with CCAM systems and procedures and already have frontline experience within the organisation. Given the current restrictions affecting external NQP recruitment, it is difficult to understand why internal progression for existing qualified staff does not appear to be possible in a similar way. From an outside perspective, there would appear to be potential operational financial benefits in retaining and developing staff who are already employed rather than relying solely on external recruitment pathways. We'd therefore be grateful if the Trust could clarify what distinguishes these situations operationally or financially and whether or not this position could be reconsidered. So in response to that question, we are aware that we already have newly qualified paramedics working in non-paramedic roles, so that may be in contact centres, mate-ready services, as well as student paramedics that are soon to qualify working in clinical support roles such as emergency care support worker. This is not something which is not unique to CCAM, it is something which we're aware of nationally. And although these roles are people that will work alongside each other, they're not in fact interchangeable roles, so we're not in a position to simply transition someone from an emergency care support worker role into a paramedic role. One of the things that is important to understand about any newly qualified clinical role is they typically will need to complete a preceptorship programme. So in England, NQPs must complete a preceptorship programme which is normally around 24 months, and that's a structured programme which requires the preceptee, the newly qualified paramedic, to develop their practice with supervision from preceptors, so that would be experienced paramedics, and they complete a comprehensive portfolio of competency. Once they've completed that, they will then transition into an experienced experienced paramedic role at a higher band, and that's when the fullness of the scope of practice, including discharge rights, etc., come from. It's simply not possible to complete that portfolio if you're not in a newly qualified position. What we would say, though, is for those that are unable to obtain a newly qualified paramedic role immediately after graduation, working in clinical support and other healthcare or ambulance service related roles can be really helpful in preparing you for when those opportunities are advertised. And I would also highlight to anyone in that position to take full advantage of the continuing professional development internal offers that we provide to maintain knowledge and skills, and also signpost people to the Royal College of Paramedics supporting newly qualified paramedics offers, which are available by the college website. And as an ambulance service, we are also working with the college to share resources where we can to provide helpful CPD for graduates that are awaiting employment opportunities.
Thank you. Very comprehensive, actually, so thank you for that.
Thank you.
I hope members of the public who ever ask these questions
Thank you.
Could I now move on to the leadership framework? I know this has had considerable discussion at People Committee, and it's now coming to the board for approval. Is that correct?
That is absolutely correct, yes. And it's a real pleasure to present this framework to the board here today. It's the product of a considerable amount of work for a number of people whose names you will see on the cover sheet. And the purpose of the framework is to establish a shared organisation-wide framework which directly allows us to deliver our trust strategy. It's a framework rather than a list of opportunities. It sets out the kind of qualities, behaviours and opportunities that are available and expected of colleagues. One of the important things about this framework is it's agnostic to a certain degree of role or seniority. We position in this framework leadership as an absolutely continuous and collective responsibility. It's not a function of hierarchy. So to the point that was made earlier, this isn't a framework for senior leaders. This is a framework for people who lead people, whether those people are senior, junior, members of the public, patients. This is a framework that is designed to support everybody. It is aligned with the NHS management and leadership framework. It's been developed collaboratively, as I suggested, with a number of colleagues, and we've managed to get a foreword to be contributed by Professor Michael West, who, as colleagues will know, supported us last year in a leadership conference. It's based around 6 leadership qualities. I won't read them out. I'm conscious you've all had an opportunity to read it. And the differentiation comes in at the different leadership levels, just really to help people to align their development to the level that they're working at, and also think to the next stage. One of the things that I just would like to draw out is the intention here. You will have seen from the framework that we have a set 70-20-10 learning model, and that's in sort of respect to the fact that really the vast majority of the leadership development occurs on the job in the things that you do in your day-to-day work. So we will continue to provide leadership development in the classroom, but that is the 10% part of it. That the real work, the majority of the work, takes place elsewhere. So, in conclusion, the very important next steps are to pull together a living implementation plan. One of the things which I think I would like to highlight is it's relatively easy to put out a prospectus of courses for the 10%. The real devil in this is the implementation plan for the 70%, for the 20%, and make sure that we provide those equitably, as we discussed earlier. Thank you.
Again, this is really excellent, and this is my last board, and I'm really pleased to be chairing a board where we're asked to approve something like this. So tremendous thanks for all the work that's been done with colleagues. I know this has been discussed at the People Committee. It's an opportunity for other NED colleagues or executive colleagues to ask any questions, but I'm very happy to endorse and approve this. But it's over to you, colleagues. Really, any questions, or are you happy to approve? Okay, I think that is a resounding success.
Michael.
Sorry, yes, Suzanne,
Mi-
please. Sorry, yeah, thank you.
Great, thank you. Very much support this, very much like the idea of a framework and a route through progression. I have one very small, well, a pedantic point really, which is in the foreword from Professor Michael West, the statement that CCAM's mission is to deliver high quality, continually improving and compassionate care to the people of the region. Those are his words, not ours. And I just wonder if we're comfortable with that. It's, it's not a deal breaker, but the way that is articulated isn't, to my knowledge, articulated anywhere else in our literature.
It's a good question, actually, and it is, isn't it? It's the challenge that you have when you ask somebody to give a forward and endorse. You want them to use their words, but I hadn't picked this up. But Sarah and Jackie, do you want to respond to that?
I think it's a very, very good point. I think whilst we don't necessarily use those words elsewhere, I suppose my thought would be, do we agree that we do want to deliver and achieve those things? And they are Michael's words, not mine. They do speak to me, and for me are analogous with the intentions of the organisation, but I'm equally happy to amend, kind of obviously with Professor West's support the statement if the board feels that different words would be more appropriate. Do you have a view, Sarah?
Yeah. I mean, I read those as his words, so it's the way he describes those. Those words don't necessarily contradict anything that's in the main document. So for me, I absolutely understand the point Suzanne's making, but we can go back and then we're ending up wordsmithing. But actually, for me, whilst the forwards are really lovely to have, it's the deep devil's in the detail in terms of what's behind that. And then the other big issue for us is then how do we assure people actually the framework is actually coming alive? And again, we will need to be really thinking through how we provide that level of feedback, because it's an inherent danger that we raise expectations. Yeah.
Suzanne, I think you make a very good point, and I really do, and it's not necessarily the words that we would use, but they're his words. If he was really contradicting anything that we fundamentally, I think I would go back, but I don't think he is. But I'm very grateful for you raising it. I think it's a very good point. And Harbhajan, I would agree with you. We're now raising expectations because we want to get to a position that, we're a high-performing, outstanding organisation. So once you raise expectations, there is a real emphasis on delivery, communication and engagement. My parting words are, and I'm sure you're going to do this, you need to bring this back to the board fairly regularly to give assurance that we are moving in the right direction with this and to get that feedback. But I think it's a really important step forward and a real marker for the organisation, and for the group as a whole. So again, my thanks and thank you for the challenge, Suzanne. It was appreciated. Can we then go on to the final section of this morning, which is sustainable partner of part of an integrated NHS, which is starting with finance. And Suzanne, thank you very much for your patience in waiting this long. But the floor is over to you now, so please. And I apologise that we preempted some of your discussion, but I think that just tells me how important the issues are. So it's over to you. Thank you.
No, thank you so much, Michael. And first of all, my apologies. I would love to have been there in person. It just wasn't possible. So when it comes to the Finance and Investment Committee, a few things really, and I presume the paper is read. I'd like to thank Paul Bartlett, our Governor, for observing. We've had observers at all of our recent Finance and Investment Committees, and it's really important for us. Because effectively they're holding us to account on behalf of the public and the people that we serve. I think it's worth acknowledging, and it's stating the obvious really in the context of the conversations that we've had today, that this committee has a really wide remit and we extend across the operations, across the organisation really. And absolutely, while we strongly identify with the sustainable partner that strategic aim. I think it's also clear, and we're very mindful in our discussions around high quality care. Liz, you'd be pleased to hear we discussed here and treat the C2 mean and the UCR performance. And also that people enjoy working with us, Harbhajan. We acknowledge the recruitment freeze and what we are asking people to do really in the context of what is a challenging and continues to be as an ongoing challenge for the organisation, to continue to deliver high quality care, but also managing our cost base effectively. So the alert, again, as with the other committees, are terms of reference in the cycle of business. We would appreciate if the board could give us formal approval of that. We're mindful, and this is directly from the report, we're mindful of the significant financial and operational risks identified within the medium-term plan. And I would very much like to thank my fellow NEDs, Mojgan, Peter and Paul, for their contributions that they make. Given the remit of the committee, I think it's really important, as again stating the obvious, that we assure ourselves on behalf of the board that we are cited on the ask and what the exec team is delivering, which is quite considerable. And again, just going back to the strategic risks and looking at that heat map, you know, risk number 4, cost improvement, score of 16. Risk number 7, cyber resilience, scores 15. Risk 8, digital function, score of 16. So we're very mindful of managing the risks within the board assurance framework, notwithstanding then something like the fire safety risk, which we're also actively managing, and welcoming the updates from the execs and our colleagues who are actively managing those very real risks for the organisation. And again, I appreciate we spoke a lot about virtual care and Here and Treat today, but also I do want to just reference fleet optimisation. I appreciate there's a paper aligned to that later on, and also reducing abstractions, which we haven't specifically addressed today, but we are very mindful of. The vacancy rate. So in terms of the ask this year financially was 4% of 13 million. I think Simon will correct me if I got that wrong. And the vacancy rate has certainly been a massive factor in managing this so early in the year. And Michael, you're absolutely right. We have to be very vigilant here because a slippage early in the year just compounds the ask towards the end of the year, which is never ideal, particularly as you go into winter pressures. The SIPs, again, very mindful of interrogating whether they're recurrent or non-recurrent. And again, while we've identified most of the 13 million or so, there's about 2 million at the moment that I think is unidentified. But I appreciate that the exec are taking huge and important steps to identify those. And of course, there's the risk that if we don't hit the C2 mean, we don't get the associated funding. That said, the exec are taking steps. For example, very pleased to hear about the weekly meetings of the efficiency subgroup. And I think that's really important to make it a live matter for the organisation because this is everyone's business. And also we had a very good discussion around some digital metrics, which again, I perceive to be a big step forward in terms of how we manage these risks, but also how we achieve the productivity gains that we want to do. I'd like to note a few really positive things. Nexus House, I think, could definitely qualify as a successful project. I know we're not there today, but I'm looking forward to us getting back there. And also the reporting, there's been the reporting, all of us at committee discussed and agreed the reporting has seen a step change and improvement. And we're not resting on our laurels. We're looking for more information, particularly around our cost improvement plans, because these are many and varied, but some are more significant than others. And then finally, you will have noted in the report, we had a recurring theme at the committee, very much driven by Paul. Thank you for that. We really want to understand how we can support the work of the Integration Committee and reflect the work of the Integration Committee. Because even though our committee is a subcommittee of the board, which of course is focused on CCAM, we are mindful that we will increasingly see programmes and initiatives and decisions which are in the interests of both organisations. So that's it from me. I'm very happy to take questions, but in the interest of time, Chair, I wonder if we should go to Simon for his thoughts, and then perhaps Nick. I appreciate David is there as well. We missed you at the committee, but perhaps Simon and then Nick, and then questions, Chair. Would that work?
That's fine, Suzanne. But firstly, thank you. A very comprehensive summary, as each of the chairs have done today, for which I'm most appreciative. But Simon, please.
I think the finance report speaks for itself. I'll not dwell on that. I think in the summary report, just by way of sort of correction, the page 1 refers to C2 being better than last year, which is a true thing. But it says it's 3 seconds off trajectory. It's actually 3 minutes or nearer 3 minutes.
Sorry.
So that again, in terms of that conversation earlier, is just it's a useful coming back round that loop, isn't it? We've got quite a way to try and correct this year to make sure the plan delivers in the way that we've described it. So all efforts are being expended, but we need to be diligent and make sure that those actions are going to do the trick.
I just want to say my prerogative of chair. So what, listening to this, and as an ed and previously an executive, you face different situations. A number of things that I draw out from this is, I don't think CCAM is unique in terms of the rest of the NHS. The NHS faces real exponential challenges in terms of focusing on the money and being able to deliver patient care. I think the better and more high-performing organisations are the organisations that understand the issues and the challenges that they face, and they're in the process of exercising appropriate management grip, and that their information and their decision-making is not just in time, it's well advanced to be able to at least begin to mitigate problems as they begin to merge. And that's how I would hopefully characterise the CCAM executive team or what the board is trying to do. But I don't want to put words into anybody's mouth, and I'm just interested about, because I hear what the excellent report from Suzanne. It seems to me we know what the issues are. It's about managing them and managing them effectively. But Harbhajan, I look at you because you've got wider experience of the NHS than I have. But I don't know what your take on this is.
My question was specifically on the C2 position, and I was wondering, having had SCAS board yesterday and finding ourselves exactly more or less in the same position, one was the issue around profiling, and secondly there was an issue around actually the heat wave and whether that also has had an impact. And it's just to try and understand that, because my understanding is actually most ambulance trusts at C2 position in month 1 has not been too targeted.
The C2 position is behind plan in month 1. It's also further behind plan at the end of month 2. And that pertains to a combination of factors. Firstly, our agreed plan for this year is challenging in terms of requiring us to deliver significantly more productive working in a number of domains, as Suzanne has articulated, right from the beginning of the year. And we have already comprehensively discussed that, particularly on Hear and Treat, but actually in other areas of the productivity ambitions we are behind, and we need to do more quicker and further actions to get ourselves back on track in terms of the productivity which is required for us to deliver that 25-minute average across the year in a suitably seasonal trajectory. It has been exacerbated, I think, by the very high demand that we saw to some extent through April, but more so through May, which has had a double whammy effect of obviously having more demand on the services. It's also impacted on our staffing levels. So we have seen some increased or lack of ability to resource, I think through the hot weather and also some kind of broader recruitment factors. So I think what we're seeing is a combination of factors driven partly by the productivity requirement being significant and not yet fully delivered, but partly by the heat and demand impacting both on the kind of supply and demand sides of the equation.
Is there anything more, because this is where the board needs to get assurance, that we could be doing that we're not doing, you know, and as you're coming in as Chief Executive, what's your take on that?
There are things that we can and will be doing. We don't at this point require sort of board escalation or approval for those things, but I think your suggestion of updating the board on the delivery against operating plan at the next board occasion is a good one, Michael. So at this moment in time, as Simon articulated, we are looking at our escalation actions through the agreed checkpoint that we've established in 2 weeks' time. And at that, we had a good discussion yesterday, and we have a range of things we either can accelerate or which we can do differently. That's, I guess, the point of our resilient organisation, trying to have a plan B in advance. But we would be really happy to update board on that in due course.
I think the point about Plan B is really important, so I take that. Nick, did you want to come in on something? You looked.
Yes, not on that specifically, but on the digital piece. Thank you, Suzanne, for the cue to that. The point to note, I think, is in the previous year that I've been here, we focused much more on foundational things, really getting sorted some of the key infrastructural things we needed to start to deliver. And what we've done this year, by really focusing on clinical productivity and corporate productivity and using data to facilitate good decision making, is we've started to tie technical digital solutions specifically much more pointedly at business requirements and business outcomes. And I think we had a very good finance and investment committee that was a signal to point more focus at the outcomes and less focus at the technology. So how can we show we're moving the dial? And to that point, we spent a considerable period of time yesterday at our executive management board focusing on those specific clinical productivity targets and how technology is enabling that, and starting to think about how best we report that, who we involve, how we engage, etc., to achieve those things. And it's something we will monitor very closely, and I'm sure we will come back to the board through the year and be able to report on how we're moving the dial by using the technology there. So I think that's a really good learning point and a key difference in what we've done over the first year that I've been here.
Okay, that's really assuring, Paul. Thank you. Sorry, Nick, thank you for that. But over to Paul, please.
Yeah, so we have seen a lot better planning and reporting. So the BAF risk, say, for virtual care, it has it going from 20 to 10 by next April. And behind that, there's a plan. We've also got plans in digital, in cyber. So we've got much better, we haven't delivered them yet, but we've got much better plans, line of sight as to what we're actually going to be doing. The task now is A, to deliver them, and B, for us to monitor them. But across the board, we've got much better reporting and tying up between the BAF and the IQR and the associated plans to deliver. So I'm really pleased with that.
Okay, again, Paul, what I'm seeing is that the information is geared in a way for us to make more effective decision making, which is really, really good. I wanted to bring this. Any other questions? Oh, Suzanne, I was going to come back to you, and I was going to ask one question of you, really. You've got a lot of experience in finance and all of this. A general observation, is there anything more that you would have been expecting the executive team to be doing at this point in time than what you're seeing? I return to my point that the NHS as a whole is so significantly challenged, but we need to be absolutely confident as an organisation that we're on this as best as we can. And you've got a particular lens there, and I'd welcome your view on that.
Thanks, Michael. I appreciate that. And very much, actually, what Nick and Paul have just referenced. It's about getting information that's decision useful. And particularly, and I appreciate Nick's engagement with looking at our outcomes and it's not enough to know the digital projects, for example, or the IT projects, it's what are they delivering. And I think increasingly where we're headed is understanding the levers that we have. So if there are projects that are not delivering, we need to be on that, and we need to understand that. But then separately, if things are off track, we need to know what levers are available to us. And then, of course, in what you'd expect in the private sector, sort of a tranche 1, tranche 2, tranche 3 approach to it, which we are heading towards, but we have to be mindful that we operate within an NHS framework, and all of you will have heard me talk about this before. It's really challenging because we're an autonomous organisation, but we work across the system with our partners, and we work within the strictures of the NHS. So a long answer, Michael, to say that yes, we're constantly improving and evolving our reporting such that it's decision useful, and the executive are doing an excellent job on that.
Okay, thank you. I was going to conclude at that point in time, and so if members of the public looking at this, I hope that you very much get the confidence that we are challenged as an organisation, but we're not unique in that space. But what we are doing is very much exercising appropriate management grip and foresight, and to take decisions that are very much around continuing as best as we can to improve the service that we deliver for the communities whom we serve. But we are mindful that we are the recipients of taxpayers' money, and that we seek to use that taxpayers' money as to deliver the best value for money that we can. And that really is how I would conclude this section and the broad assurance debate that we've had over the last hour and a half. So I think that concludes. Is that, yeah. Ladies and gentlemen, this is my last board, as you all know. I did want to say something in the public domain. I promise you faithfully, it's not anything like an Oscar acceptance speech. I will be very, very brief. But I did just want to say genuine thanks to 3 groups of people. Firstly and foremost, I want to thank my non-executive colleagues, the colleagues that I'm working with at the moment, and also those that I've worked with in the past, particularly the former chairs, David Astley, Dr. Usman Khan, but there are other people that I could name that some of you will remember, some of you won't. Laurie, Max, a whole range of people. And there's one person that I do want to single out in particular, who sadly is no longer with us, and this is Patricia. When I joined in 2018, Patricia had been here with Laurie for about 9 months, and very sadly during COVID, she had pancreatic cancer and she didn't survive. It was very quick, is often the case with that disease. But you are influenced by the colleagues that you work with, and I do actually still think of Patricia because she did have a big impact in terms of the focus on culture. She was very interested in the cultural journey that CCAM needed to make. And I always remember her words to this: don't forget, you're here to challenge, but you're also here to support the executive to deliver their best. So, you know, I did want to make that reference to her. I also want to draw out the support that I've received from Karen and Liz. I was determined when I took up this role not to be one of these chairs that it's just about the chair, because you can't do this sort of job on your own. And what I've been very keen to do is make sure that we worked as a team, and Liz has been really excellent in the advice that she's given me in the clinical space, and also, you know, drawing on your experience of managing hospitals, managing significant workforces. And Karen, I literally do not know how you do all the work that you do in the time available. You work so hard, and you've given such good advice, and you know, you really demonstrate, as does Liz, the values of CCAM. I do also want to make reference to the governors. You know, I've heard in the past from different trusts, watch the governors, you know, you've got to manage how this happens. I would genuinely say this, that the governors have been brilliant. We've got Andrew here today, and Andrew has been really excellent in the support and advice and challenge that he's given. but also Lee, and before Lee, was it Felicity who was here? I think it was, I can't remember. But all of them have been really excellent, and your colleagues on the COG, I can't name everybody, but have been really supportive. And I know what has always been and continues to be at your heart, which is the benefits for patients and all the work that you do as community first responders. That's my first group of people. My second group of people is to single out the executive. When you get to my age, I've had 25 years, well, more than that, I think, as an executive, sitting on boards, evaluating boards, both nationally and internationally. And I generally can tell you now, I've seen what good looks like. And the executive team here is really, really excellent. You have so many skills, and what you have achieved is really great. One of the nice things that you get as you get older is that you begin to see people that you've worked with who are younger than you go on to do some really, really excellent things. They go on to become chief executives. And I'm pretty sure, well, we already got one, but I'm sure that many of you will go on to become chief executives or hold more senior posts within the NHS and more widely. And all I'd say to you is have confidence in yourself. You're more than capable of working with SCAS colleagues to deliver the group model and all the benefits that are intended. Within that group, I will also say tremendous thanks to SCAS colleagues and also particularly Keith. Behind closed doors, Keith and I go back a long way. I haven't got his pedigree, but I have engaged with a number of people that he's engaged with, David Nicholson, Committee of Public Accounts, a whole range of politicians. And we often didn't agree, Keith and I, but what we both agreed is that we walked away from this as friends, and that's really, really important. And I admire him tremendously for what he's done for the NHS and will continue to do so. And I know at his heart was always the best for patients. And I think we've got to a result on which we can build some really strong foundations. So I thank him and I thank SCAS colleagues as well. And my final group of people, it has to be, and can always be, the CCAM people that work within the organisation. And obviously the focus has always been on paramedics and other healthcare professionals, but I extend my thanks also to everybody who works in corporate services, people who we contract with, community first responders. Amazing what they do, but ultimately CCAM is about their delivery and the extra mile that they go for patients. What I will always remember is the welcome and kindness that they've always extended to me. So if any of them are listening, to a board, I'd like to conclude by saying genuine thanks to all of you. And that's it. It's a wrap, as they say. It's all over. So it's over to you. Thank you very much.
Yes.
Thank you.
Michael, it's. Can I put my microphone on? It is over to us, and let's hope you never do actually win an Oscar, because you've given your acceptance speech before we've had an opportunity to present you with the obligatory. I don't know if at the Oscars they have this kind of challenge of getting the little statue out of the box. But we need to present you with your CCAM shield.
Thank you very much.
And a token of our appreciation will be on its way to you.
Thank you very much.
And I just wanted to say, firstly, in acknowledgement of everything that you've said, Michael, it has been an absolute pleasure to work with you as a NED and as chair. I can't congratulate you enough on your wisdom, your compassion, your support. You've really guided us very wisely and skillfully through lots of challenges and really helped us on the journey that I've seen. So on a personal level, as well as the shield and the cards and the token, thank you from me. And I think I speak on behalf of all of the executive. I think both Karen and Andrew would like to say something also. So sorry to embarrass you for a few more moments.
Thank
I'll
you.
hand to Karen.
Thank you. Well, as many of you know, the chair's appointment is actually a governor's appointment, and we were delighted, of course, when Michael said that he was prepared to hold this sort of interregnum, really, between Usman going and wherever we've ended up and where to end up with Colin and the rest of the group model as that goes forward. I mean, I echo entirely what Jen's already said, and I'm sure what Karen's going to say. But I know, I think probably more than many, the challenges that Michael's had in the last few months to try to steer the overall governance of the trust and the group model together, and trying to find the best way forward without probably just losing whatever hair Michael's got left. You've put us in a very strong position, I think, Michael, with all that you've done. The testimony to that is probably partly the CQC recent rating, and I think that it's clearly a team effort, but it's a very strong legacy that you leave behind. You have been a passionate advocate for the staff, for our patients and the communities we serve, and I've seen that, and governors have seen that at first hand. And you've led us with integrity, guidance, and very good sense. I think you've asked many strong questions. I've seen one or two bottoms sometimes wriggle on a chair thinking, what are we going to say to that answer? And I think that's very positive. But as you've rightly said, Michael, you've dealt with that in a very compassionate way, and you've kept the organisation on track. So it's a huge sorrow that you're going, but time served and all of that. I'm absolutely assured that as you go into retirement from here, Peter is very happy to continue to send you the board papers should you slip into an insomniac medical condition, just to try and help you to sleep overnight. But many of you know I'm a volunteer with St John Ambulance as well as the Trust. And at the heart of St John Ambulance, we have two mottos. One is about faith, it's Christian Order of Chivalry. The second is Pro Utilitate Hominum, which is the service of humanity. I think that highlights to me, Michael. It's about humanity, about service, and what you've done for this trust and what you've done for the wider community is evidenced in the fact that you're a holder of as an officer of the most excellent Order of the British Empire. You're very humble about that, but that's a huge accolade. Thank you for what you've done on behalf of the governors. We wish you well for the future. And thank you to your family, who I'm sure have had one or two moments that have been a bit tense. We're very grateful. All the best. Thank you.